Good afternoon. The Senate Finance Committee is now in session. This afternoon, we have 7 very important bills. I'm sure they all are. I'm just going to run down the list. We're starting with Senate Bill 805, Senator Peters, then 796, Senator Eckhart, 719, Senator Zucker, 685, Senator Lamb, 729, Senator Feldman, 748, Senator Bidle, 705, Senator Bidle, and 682, Senator Kramer. Now, as I think all of the members know by now, the lead proponent, as selected by the sponsor, will have 5 minutes. The sponsor has whatever time is needed to lay out the parameters of his or her bill. And all other witnesses will have 2.5 minutes each. And so welcome, Senator Peters. You're on now for Senate Bill 805.
Thank you, Madam Chair. This is a bill, normally I not delve into these areas. You are the experts regarding auto insurance and zip codes, but I've had some constituents with issues, particularly in Prince George's County, where they've actually moved from one zip code to the other and their rates have gone up, their auto rates. So all this bill does is promote the transparency of the auto insurance markets by reducing the use of a territory and zip codes and auto insurance pricing. That's the nuts and bolts of it. And if I could, I'd turn it over to my committee and my panel, I'm sorry, and allow them to speak.
Okay. In that case, then we're going to start with Douglas Heller.
You have to call him again.
Douglas Heller. Is he here?
Yes, I am here.
Okay, then you're on next.
Okay. You ready for me?
Yes.
Thank you. Sorry about that. Well, Chair Kelly, committee members, my name is Doug Heller. I'm here on behalf of Consumer Federation of America in support of SB 805. Because Maryland law requires all drivers in the state to purchase auto insurance, the legislature has a special responsibility to ensure that coverage is affordable and fairly priced. But in some communities and for people with certain socioeconomic status, auto insurance is often unaffordable, even for drivers with perfect records. And this creates pockets of high levels of uninsured driving, and that costs everybody. Now, the first element of the bill will remove the special privilege insurers have in Maryland to prevent the public from seeing how they use socioeconomic status to set the price of coverage. Insurance companies now may tell you that this is their secret sauce and the market will be less competitive if they have to reveal it. But the fact is, this is already public data in several other states. For example, I can download right now companies' pricing recipes for drivers that are used in California and Connecticut. And those states are ranked number 2 and number 5 in terms of market competitiveness. Now, on the other hand, even with this secrecy, Maryland has the 5th least competitive market according to the Standard Department of Justice Index. So you won't be sacrificing competition, but you will gain transparency with the first part of the bill. Now, one of the pricing factors that plays an outsized role in auto insurance is zip code. The second part of the bill addresses the fact that the use of territory results in extreme price variation between safe drivers due solely to where they live. So for example, one of the state's largest insurance companies increases premiums from $592 per year for a basic coverage policy in one part of the state, all the way to $2,687 for the exact same person for the exact same coverage if they live in another part of the state. That's a 354% premium hike due solely and entirely to zip code. Now, while that huge price difference reflects premiums charged in different parts of the state, the pricing policies based on small territorial units of zip code leave some drivers paying much more than neighbors right across the street. So in Baltimore, depending on which side of Pimlico Road you live, your premium could jump by more than 80%. One major insurer charges about $2,000 a year for basic coverage to a driver living on the 21209 side of this boundary. But if you live on the 21215 side, the company charges the exact same driver almost $3,700 for the same exact coverage. Now, both of those examples, the 354% premium for drivers living in different parts of the state and the 82% price hike for people living on the wrong side of the street, have another important thing in common. The residents of the lower priced, less expensive zip codes are, by a very large majority, white. The residents of the higher priced zip codes are, by a very large majority, Black. And this is the underlying story of the current system of territorial pricing in Maryland. Data that we have reviewed from the insurance industry for every zip code in Maryland shows clearly that as the percentage of white residents in a zip code declines, the premium increases. The zip codes with the highest percentages of people of color pay the highest premiums. Now, while insurers will doubtless argue that this racialization of auto insurance pricing is not their intent, it is the outcome of pricing practices that are currently allowed in Maryland, and a clear example of how systemic bias, even if unintended, persists. So this legislation offers two different approaches and asks you as the legislative committee to think about them and come up with the best response. But it offers two approaches to diminishing the impact of zip codes. It does not get rid of the use of zip codes, or at least it does not get rid of the use of territory. The one offering is to increase the size of the territorial pools in which drivers are grouped. Rather than using the small groupings that arise through zip codes, this approach would have insurers spread the risk more widely across 5 larger territories around the state. This would still allow for carriers to distinguish between actuarial differences they might find in one part of the state compared with another part of the state, but it will also ensure that people who live in generally the same regions will pay the same territorial rating. And this addresses one of the key flaws of zip code-based pricing. Where you live does not describe exactly where you drive. By requiring the use of broader regions, rates will more likely reflect the actual regional risk differentials rather than rates that switch every few miles according to an arbitrary postal service boundary. Now, the second approach, as I wrap up here, the second approach would allow insurers to continue to use zip codes as they have, but it would cap the price variation created by the territorial factor at 25%. So you wouldn't have these 82% jumps from one zip code to another zip code. It means the companies could still use zip codes and charge higher or lower rates, but the differences would not represent more than a quarter of the total rate. This would require insurers instead to place more emphasis on people's driving safety record and than where they live, and it will still allow them to use zip code to a significant extent. Now, CFA, Consumer Federation of America, we believe that there actually a third approach would be just the merging of these two different options that are provided to you. And combined, that would be the most effective response to the disparate impacts of the current territorial rating system. This would be an effective way to spread risk, preserve the use of some territorial rating, and dramatically diminish the chance that the use of geography disproportionately harms people of color and low-income drivers of the state. SB 805 will promote transparency and accountability in the auto insurance market. It will reduce the number of uninsured motorists, and it will reduce the unfair outcomes that leave Black and brown communities in Maryland facing significantly higher premiums for the coverage that everyone is required to buy. And so for those reasons, we hope that you will pass this legislation, and I'm certainly available to answer any questions. And thank you for your time.
One question I would have is, I didn't see written testimony from you, and you weren't required to, but some of your oral testimony speaks to variables that I don't see addressed in some other people's written testimony. Maybe it won't be before us in oral testimony. If you could get that to us, I think it would be helpful for the deliberations of the committee.
Absolutely. I was under the impression that I had properly submitted the testimony 2 days ago, but it's a little bit of, I may have done it incorrectly. I'll make sure that I submit it to the committee.
Okay, thank you.
Yeah, thank you.
Are there questions of this witness? Okay, if not, then we're going to Marceline White. Consumer.
Good afternoon, Chair Kelly, members of the committee. My name is Marceline White. I'm the Executive Director of the Maryland Consumer Rights Coalition, MCRC. And MCRC works to advance economic rights and equity through research, education, consumer outreach, and direct service. And we're here today in strong support of SB 805, and I want to thank Senator Peters for bringing this legislation. Chair Kelly, as you know, this committee has looked at and talked about auto insurance for many years now. And I know you've had another bill this session that we're supporting. What I want to do, though, is focus on two areas that Mr. Heller discussed and discuss the impact in Maryland. As we can see, and I will share a policy report that was released the other day on the use of zip codes in Maryland. Whether intended or not, the use of zip codes in Maryland has an extraordinarily disparate impact on Black and Brown drivers in our state. And what that means is that the more diverse a community is, the more they pay in auto insurance. Now, again, whatever the intentions are, it is the opportunity that this body has and the goal of this body, especially this year, to look at equities and to change those. When something discriminates, it's the opportunity of this body to right that wrong and address this discrimination. So what we're asking you to do today is to do just that. This does not conflict with state and federal regulations. It does not make the market less competitive. It simply smooths the market so that a driver in one part of Prince George's doesn't pay $200 more than someone 2 miles away. Similarly, a driver in Pimlico doesn't pay $600 more than someone in Mount Washington. You can still use territory as a rating, as Mr. Heller said. But we've done a lot of work, and this committee has done a lot of work in terms of creating lots of sticks, I would say, fines, fees, criminalization for people who don't have insurance. We haven't done as much work on making it affordable. This makes it more affordable, especially for lower income drivers, particularly right now when we know that so many people that are driving are essential workers and we need to be supporting them, and they often reside in these communities that are charged higher rates. The second thing I'll just mention is, again, this issue of transparency. This is something the General Assembly voted on just a few years ago. Until then, we did have open, transparent records. And you'll hear the opposition talk about how people need to shop around for insurance. But it's very hard to shop around for insurance if you don't know how much these factors affect your rating. So actually now we have less information than we did 4 or 5 years ago to actually make those informed decisions as consumers. And
I
certainly,
wish we had more time.
I will leave it at that. I will simply say
Okay.
we think this is an important bill, Senator, and we hope you give it due consideration, and we ask for your support of SB 805.
Thank you. Are there questions of this witness? Okay, then we're going to the Reverend Kobe Little, the NAACP Maryland.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. I'm Reverend Kobe Little. I represent the Maryland State Conference of the NAACP. And we're here today in support of Senate Bill 805. I want to thank Senator Peters for sponsoring this legislation. You've heard my colleagues describe what this legislation does. I would just like to frame why you must take action now to pass this bill out of committee. We've heard from the previous witnesses that in auto insurance, we still have redlining. And the insurance industry will say that it's not their intent. They're sympathetic to equity issues, but they're not at fault for why Black people end up paying more for auto insurance. The state of Maryland requires every driver, every automobile owner to have automobile insurance. And as such, the state must regulate the auto insurance business. If the industry says that they're not responsible, and they also say that they can't figure out how to have more equitable rates, then the burden falls on the state of Maryland to ensure that all drivers are able to access equitable rates and that there's not racial inequity in auto insurance. This is your moment to shine. This is your moment to do the right thing. Don't be bewildered. Don't be burdened by a multi-billion-dollar financial services industry that will come to you this afternoon and tell you that they're the victims in this equation. As Ossie Davis said 30 years ago, do the right thing. Thank you, senators.
Are there questions of this witness? All right, then we're going next to Christopher Dews, Job Opportunity Task Force.
Wonderful. Thank you, members of the committee, for having me. My name is Christopher Dews, and I'm a policy advocate for the Job Opportunities Task Force, where our mission is to help lower wage workers advance to higher wage jobs. We support Senate Bill 805 as a means of decriminalizing poverty and ensuring that auto insurance is affordable for lower income workers and job seekers. We specifically want to focus on this from an employment perspective and a workforce development perspective. Mobility is key in Maryland's regional economy. I've said this before. The U.S. Census Bureau reported that more than 47% of Marylanders drive cross-county for employment, and that only in this time period, 45% of Marylanders can telework, which means 55% cannot. The statistic is more pronounced in Black and brown communities of color, where there's a scarcity of jobs available by public transit. As you also know, the Baltimore Sun reported recently that only 9% of jobs in the Baltimore region can be reached 1 hour one way by public transit. So having a car and auto insurance is necessary if you want to maintain employment in the state of Maryland, specifically if you are a lower skilled worker who, let's say, for example, does not have a college degree. As you also know, 500,000 Marylanders, as reported by Maryland Auto, drive uninsured, most citing the cost of auto insurance as the reason for them taking that risk. This is due to factors like zip code. I'm not going to repeat anything that my colleagues have already said. I will say that Maryland Consumer Rights Coalition did mention in one of the studies that they had that a 30-year-old man in Baltimore City pays on average $500 more than he would pay for the same insurance in Montgomery County. I also want to mention that Maryland Transportation Code 17-107 states that if you drive without insurance, it's a fine of up to $1,000 or 1 year in jail or both. And so every time these 500,000 Marylanders drive uninsured, I mean, this is a real problem. Specifically for our constituency, we have a pre-apprenticeship construction training program called Project Jumpstart, where we train Baltimore City residents. We get them the certifications, we get them the skills in construction, carpentry, electrical, and plumbing. Then we get them a car. But now it comes to auto insurance, and we're finding out that our people are paying anywhere from $300 to $650 a month. That's what they're being charged in liability only coverage because they live in a specific zip code or don't have enough credit or anything of that nature. So now you're telling a person who's got a job for $50 an hour, $30,000 a year, that 12 to 25% of their income before taxes has to go directly to auto insurance. And then, maybe if you keep driving long enough, that price will drop down. And when people can't afford it because they have families and children they have to take care of, and they have to pay for gas and maintenance of their vehicles and all the other expenses that people have in this COVID-19 times, zip code is just it becomes unaffordable. So for those reasons, we urge a favorable report. This is going to be great for workforce. It doesn't get rid of zip code. It just minimizes the use of it, and it spreads it out so that it's much more equitable. And as the Reverend Kobe Little said, doesn't reek of redlining. For those reasons, we urge a favorable report. Thank you for your time.
Thank you. Are there questions of this witness?
Senator Hershey.
Senator Hershey. You got to unmute yourself.
Thank you, Madam Chair. My apologies. I was wondering if I could ask Mr. Heller a question if he's still on. I did find his letter that you had mentioned.
Okay.
Mr. Heller, I see that you're talking about the difference in price based on the same exact person. What was there a study or something, or how was that determined?
Yeah, thank you, Senator. My organization, Consumer Federation of America, purchased a premium quote for every zip code of Maryland from 10 of the largest insurance companies. We bought it from an insurance industry provider of this data called Quadrant Information Services, and it's based on the actual filings of all carriers of the carriers in the state. So we did this analysis. And all we did was we changed the address. In every case, it was the same exact driver, same driving record, the same car, the same miles a year. And the only thing we changed was we looked at the different addresses. So this is industry data that's Consumer Federation of America purchased in order to do an analysis of rates in Maryland.
I'm sorry, go back to, this is data that you purchased. So
Yes.
this is not actual evidence. This is explain that again. I'm sorry.
Yeah, of course. And I apologize if the connection is bad, but
Yes, a little bit.
yeah, it seems the insurance industry does file rates with the state, and they follow those rates. Quadrant Services, which is the provider from whom we purchase this data, they actually gather the specific rates that the companies are required to charge each customer. So these are the actual rates that would be charged to a customer. We didn't go and interview drivers in every zip code. Instead, we took a profile and we applied it to each of the companies' pricing systems using the data that Quadrant is able to obtain, and we acquired.
Everybody, and so real
this
clear.
is
Is
actual.
Quadrant Quadrant?
Yes, and I believe that is I
And you
cited
just
in the
say
testimony.
Quadrant Information Service.
Yeah, Quadrant
That's
Information Services. Like, for example, they're the people that provide the data for the zebra. If you were to go online to get your quote from the zebra, that's how they get their quotes, from the same company. And they make it available to the insurance industry and to companies like Quadrant, and also to nonprofit organizations for sale.
Okay, I appreciate that. I was a little
these
concerned.
are exact precise quotes.
Yeah, in reading the testimony, when you said the exact same person, I thought you might have had an individual that lived in one place, ended up moving, goes to a different insurance company.
Yeah, no, it's a very good question. No, we just use the exact same profile as a way to compare apples to apples.
I appreciate your answer. Thank you very much. Thank you, Madam Chair.
All right. Are there any other questions? Okay, then we are going to move to the unfavorables. Marta Harding for State Farm.
Good afternoon, Madam Chair, members of the Finance Committee. Pleasure to be here today. I'm going to focus in my testimony on one piece of the bill, and I think Mr. Kirkner after me is going to talk about the territorial rating piece. My testimony is going to focus on the bill's proposed repeal of the trade secret protection that Maryland law provides for insurers' proprietary rating models, making them publicly available. These models are the complex mathematical and statistical formulas and algorithms that companies spend millions of dollars to develop to compete in a highly competitive marketplace and best match price to risk. Now, the rating factors themselves may be common between insurance companies. All insurance companies may use a particular rating factor in one form or another. But what is unique to insurance companies individually is how they blend those factors together to develop the actual rates. If you will, this is the recipe that we're talking here, not the ingredients. The ingredients themselves are public information when we make a rate filing with the Insurance Administration. What is not public under Maryland law are the formulas that companies use to compete with each other and how they blend those formulas together to come up with a rate. Maryland is like the vast majority of other states that protect these models from public disclosure, recognizing that it would be antithetical to competition. This committee, many of you may remember, in 2016, we needed to clarify Maryland law. Senator Feldman, the vice chair, introduced the bill to ensure that these models are protected and that we don't injure competition in Maryland by making the models public, as a result of which companies would move to less competitive models and competition would not be as robust as it is. I want to make clear that Maryland law does not protect these models from the regulator. When we make a rate filing with the regulator, we've got to file the models. We file whatever they request, but certainly including the models. So we are not protecting the information from the regulator, but the fact that the information is filed with the regulator means it could become public if Maryland law didn't protect it. The last thing I would say is the Public Information Act, since its inception, has protected companies' trade secrets from public disclosure. So this is no different than what our Public Information Act has always provided for competitors in the commercial marketplace. So for those reasons, we would ask that the committee give the bill an unfavorable report. Thank you.
Let me interject, Marta. You gave us a clear explanation. But if we are getting disparate impact on demographic subsets, including people who largely are likely to be essential workers, based on the small zip code divisions that you're using, such that anybody who would do the kind of inquiry that Mr. Heller did were to find similar results. What would be wrong with your having to alter that, your basic parameters, the way you determine your rates, so that larger territories and less demographic related smaller territories were included?
So, Senator, Madam Chair, I would say, first of all, with respect to the rating models themselves, this does not relate in any way to the development of territories. This is how we would blend territories into the model to come up with a rate. And Ms. Marceline,
well, you've been good at telling us what you do.
Yeah.
We're finding a disparate impact that has demographic disparities that are unacceptable to anybody in the general public concerned about fairness to people who happen to live in low-income communities, zip codes, and are likely maybe demographic minorities.
So, Chair Kelly, I will say two things, and I think Mr. Kirkner is going to get more into the territorial rating aspect of the bill. But territory is absolutely related to risk, and insurance companies have to price their product to match the risk that the individual poses. And territory has a very strong relationship to the risk that an individual presents, to their potential claim costs. And so for those reasons, and the Insurance Administration, of course, reviews all this. If there isn't that connection, we can't base it on territory. But the link is so strong that it has always been authorized by the Insurance Administration because there is an actuarial difference.
Has not moved to suggest that other parameters ought to be included or included differently. How does California, I think that was one of the two states mentioned, get away with using much larger territorial parameters to determine their risk?
And Mr. Kirkman may be able to speak to this. I think that their law restricts the use of territory. And again, it's a question of how you're going to spread the price. The cost of insuring is the same. It's a question of how you spread it across territories. And California said you have to do it a certain way, and that had implications for the way insurance was priced in California. It had the effect of spreading the risk out and spreading the price out from higher cost territories to lower cost territories.
And that seems to be what people are talking about who are proponents of the bill, the need to have it less impactful on people who simply happen to be poorer or Blacker.
Madam Chair, I would just say
that you understand why that would be concerning. I know you didn't set it all up, Marta. You're just representing.
No, I'm happy to try to, and I want, you'll be hearing from Mr. Kirkner, but first of all, it's not a question of rating based on race. That is absolutely not what insurers do or could do or would want to do. It is a question of matching price to risk. And if you look at one territory compared to another, if there is a distinction between the risk that is presented in one territory versus another, insurers take that into account in order to best match the price to the risk. And that's what happens in a competitive market.
Okay, but it does also happen that in the United States, zip code level carving up of territory often does become just a stand-in for a variable to stand in for race. It isn't necessarily anybody's intention, but it's the way we're living. It simply is that we're not that well integrated geographically. So when we do it zip code by zip code, you're likely to get down to the level of race and to socioeconomics, wouldn't you say?
Chair Kelly, I would disagree that it is a stand-in for race. It is not. It is a
I'm
matter
not
of
saying that
looking.
it's intentional,
Yeah,
but inadvertently, because, okay.
Yeah.
Okay, anybody have any other questions
Thank you.
of this witness? Huh? Okay, all right, then we're going to Andrew Kirkner for the National Association of Mutual Insurance Companies.
Hi, good afternoon, Madam Chair, members of the committee. Andrew Kirkner on behalf of NAACP. Just by way of quick background, NAACP is a trade association, more than 1,400 member companies, 11 of which are headquartered in the state of Maryland. Before digging in, and Madam Chair, I'll jump straight to some of the questions you just asked. Before digging in to territory specifically, I would just point the committee also to some written materials that were submitted as well, also on behalf of APCIA, in addition to others in the industry. I want to talk specifically about territory as a rating factor. As I understand, there's been no amendments put forward to the committee, so this bill does, in fact, as it's currently constituted, prohibit the use of territory. The use of territory is both actuarially sound and not unfairly discriminatory. As Ms. Harding just referenced, the MIA looks at all rating factors and must determine those two things under existing state law. This committee, Madam Chair, as you just intimated, is the one that makes a determination as to whether the use of territory is fair. And so I want to talk about why it is fair. Insurers, and I think most people would agree that as a consumer, as the proponent said, the state of Maryland requires consumers to carry insurance. And I think we could all agree that we should pay for a product, what it cost, right? And we should pay a premium in the insurance world that relates specifically to our risk. And so insurers in a competitive marketplace are seeking to, as accurately as possible, price your risk as a consumer. I mean, as an individual, as much as they can, they're trying to drill down and figure out what risk it is you present. So territory tells us some things, and it tells us some intuitive things, right? In more populated, highly populated areas, it tells us about density. It could tell us about accidents. It can tell us about crime and auto theft. It can tell us about fraud. It can tell us about miles driven. It can also tell us about road conditions. So these are very tangible things that territory tells us about a consumer's risk. Speaking specifically to zip codes is a way to carve up the entire risk profile of the state and drill down on those levels of risk. Again, because they tell us things like density, accidents, and miles driven. Madam Chair, I'll end there, but I would close in saying that making fewer territories or reducing the use of territory altogether is not going to make insurance more affordable. It is arguably going to do the opposite, and it certainly appears that it would in effect make a subsidizing effect for the majority of Maryland consumers. So I'm happy to answer any questions that you might have, Madam Chair, or any other members of the committee.
Okay, I can understand you're saying that territory matters and that density matters, but would you say that a person who is an essential worker, who lives in a fairly dense community, and who's a really good driver, maybe never had an accident, is still likely to be charged more if you're focusing on very small quadrants and categories of density, just to get to work and to get back, so that for people with that income and job profile, they're going to have to pay more, even if they're very safe individual drivers.
Madam Chair, I would say two things. One, I think I would agree with you wholeheartedly that affordability is not only something that we should work on and focus on, but speaking specifically to the density piece, whether an individual is a good driver is certainly a component of their premium, right? That's something that an insurer looks at. You look at driving record, accidents, things like that. But also where someone lives matters, right? I mean, the road conditions in different parts of the state are not the same. The density, the number of accidents, crime, and auto theft are not the same. And so,
Well, you know, the thing you aren't mentioning though is where they drive. When you look at your entire pool of drivers, it's where they live, because people who live in more affluent outer suburban areas end up driving in the same territory intermittently through, and sometimes daily, where the people who are charged more live. But obviously, if you got people from the rural and suburban areas all driving through someone's territory, then because they live in that territory, they are charged more. It isn't really fair.
Madam Chair, I would say you're exactly right. Zip code not only tells us where somebody lives, but I would say it gives us a lot more information, right? It tells us, and each company does this differently. I would tell you that we have 1,400 member companies. There may be 800 different combinations of how territory is used, but it does tell us where folks drive, right? I mean, companies are looking, and in a competitive marketplace, they're weighting these things differently and trying to figure out how they can most accurately price the risk so that they can charge the lowest price to get you in the door. So zip code tells us where folks drive. It's not just about where they live.
Well, I live in Randallstown, but my district abuts Carroll County. The people right on the other side of the line in Carroll County are paying less as they drive through my neighborhood. And they're coming through daily, just the way I have to move about daily. And I'm asking, is that fair?
Yeah, I think, I would say, Madam Chair, I think fair is for the consumer to pay what the product costs, right? I think, and the more accurate we can be on that calculation, I think the more fair it is. There's always, unfortunately, regardless of how you sort of, cut up the pie, for lack of a better analogy, where you draw those lines, there's always going to be situations where one person here is paying more than one person here, right? There's always going to be a line and two different sides of that line. Zip code helps us drill down in a very narrow and specific way to find what a risk might be in a geographic territory. And so it's one way of doing it. It's an accurate way of doing it. And again, I would point to, in a competitive marketplace, companies, and I haven't said this, but I think it's important to point out, there is zero obligation on companies to use territory. If an insurance company tomorrow wanted to come out and launch in Maryland and not use territory and thought they could beat the price, they could do that tomorrow. There's nothing that would stop them from doing that. This is a way to more accurately gauge the risk of a driver and then to charge the commensurate premium.
Okay, let me go to questions from members. Senator Hayes, and then Senator Benson and Senator Bidle.
Thank you, Madam Chair, and thank you, Senator Peters, for bringing this legislation to the committee. I've introduced similar legislation in the past, and mainly because of my own experiences. I used to live in a predominantly white community in an apartment building where I was renting with 200 other residents, and most of the places around there had the same level of density, 200 to 300 residents, right in the smack of downtown Baltimore and Mount Vernon community, 2 blocks away from the interstate. When my wife and I moved to a more residential neighborhood with detached homes and far less density, but predominantly and overwhelmingly African-American, our insurance literally doubled to the T. I know there's been a lot of conversation nationally as it relates to equity. I wonder if, to the chair's point and to my point, and and looking at my life experiences, have there been any conversations nationally about looking at the way we apply insurance through an equity lens to alleviate some of those concerns that we have that these zip codes may disproportionately be affected?
Senator, I think that was to me. Is that right?
Yes.
Okay. All right. Thank you very much. And I should have mentioned this in my testimony. I wanted to be very respectful of the time limits. Both the National Association of Insurance Commissioners and the National Conference of Insurance Legislators have begun these discussions. I think early last year, both groups formed task forces to look at the impact of race in insurance. Those span a really wide gamut of issues, but one of the things being looked at before both bodies is specifically rating factors. So we've, and Senator Hayes, you know this, we've had this discussion before on other rating factors. Those committees are taking a dive into these rating factors. They are taking input from not just the industry, but from consumer groups and having really an in-depth discussion about what is equitable and fair and what makes sense. So those discussions are ongoing right now. I would be hesitant to preview for you when we might expect substantive work product from those groups, but I can tell you that the MIA is involved in those discussions as well as part of their membership at the NAIC, and those discussions are ongoing.
I think it'd be
I'll
really
just
helpful.
say for 12 years, I attended all the NAIC meetings when I sat on the Interstate Insurance Product Regulation Commission. And I've been to some for encore, so I've got addresses if somebody wants to them and ask that. But we might want to put it together, a position paper, even if it doesn't make it during this session, and send it to each.
No, I agree, Madam Chair. If they could, if there's some information that we could look at, whether it be position paper or research, I think it'd be to the benefit of this committee, because I think these are legitimate concerns in the community. They'll continue to come back to this committee over and over, but if we could look at ways to address it, it's definitely a real issue that we're looking to solve.
Okay. Senator Benson and then Senator Bottle.
Yes, thank you, Madam Chair. We've been going down this path for a long time. This is a problem. Redlining continues to be a problem. Let me cite for you an example. My nephew was going to school, and so he got insurance. He had to have insurance for his car. And the insurance, when he was living with me, was over $1,800 a month, $1,800 every 6 months. He finished school and moved back to Hagerstown, Western Maryland. And the insurance on his car now is less. He told me that his insurance every 6 months is less than $1,000. It's about 800 and something. Every 6 months he pays $890 or something like that. That's a problem. And guess what? Where he moved is where he is basically the same kind of pattern that you find where I live. The second thing is I live inside the Beltway, and the insurance on my house is shameful. And so the question becomes, it does have to do with zip code. Because when I talked to my close friend in Fort Washington, her insurance on her house, the same kind of house that I have, is no.
We're sticking to car insurance though today.
So the question becomes, do you believe that are you trying to tell us that this bill is not justified?
Senator, I would respond a couple ways. One, you said it has to do with zip code. You're correct. It does have to do with the territorial determination of where a car is garaged. So
you think that's fair?
I do think that's fair. I think it's fair to charge a consumer what the product costs. I think that's actually the most fair thing to do, is to figure out exactly what risk a consumer is as accurately as we can. And in a competitive marketplace, again, insurers want to have your business. They want you in the door, and they're competing on price. And in a competitive marketplace, I think the most possible fair thing is to figure out what a product costs and to then charge that number to the consumer.
Okay, Senator Bottle.
Thank you, Madam Chair. And my question is for Mr. Kirkner. Is Maryland the only state that uses zip code?
No, Senator. So let me step back for a second. It's not necessarily that the state of Maryland, uses zip codes. It's that insurers, by and large, would break out their territory that way. That is I want to make sure I'm giving accurate information to the committee, so I won't put a number on it. But I would say that is the overwhelming majority of how insurance is determined across the country. So in states across the country, zip code is the most readily available territorial breakout, if you will, at sort of a narrow level.
So, Mr. Kirkner, do we see this kind of discrepancy in other states where one zip code is so different than another?
Yes, Senator Bidel. I think what you see is, for the reasons I listed before, whether it's auto fraud, whether it's, car theft, whether it's density, whether it's potholes, whatever the case might be, we do see discrepancies between more populated environments and less populated environments. I mean, that really is the basis, by and large, of territorial rating, is that there are risks that are different, in more densely populated areas than there are in more sparsely populated ones. And there's there's many other factors that an insurance company uses. This is one of those, but it's very telling, for the substantive reasons I listed before.
And thank you, Mr. Kirkner. I was going to bring that up. It's marital status and sometimes education, credit, distance to work, age, all those things also count in the rating. It's not just territory, but thank you for your answers.
Okay, Senator Augustine.
Thank you, Madam Chair, and thank you for the testimony. I'm looking at I understand what you're saying here, Mr. Kirkner, and I'm looking at the written testimony from AAPCIA, and in there, it talks about the auto loss costs and doing it on a regional basis and stuff like that, and I get that. But it looks like the data is coming from basically from yourself. I mean, is there an independent group who can actually validate that this is actually fair? In other words, going back to the conversation around redlining, I mean, the banks were able to provide information that said that it didn't exist. I mean, because the banks were providing the information, right? What do we have? Do you have something that is truly independent? Because this information, ISS, is not independent information. Do you have truly independent information that shows that this is not redlining?
Senator, I would point you in two directions. One, I think, and obviously that depends on the definition of independent, right? But what I would tell you is that the Maryland Insurance Administration reviews every rating factor to make sure that they are two things: one, actuarially sound, and two, not unfairly discriminatory. So that would be the first place. The second item, and I don't know if they've submitted written testimony to the Senate. I know that they submitted written testimony in the House, but MAIF has also broken out some of this data. And so again, that depends on, perspectives on independence and so on and so forth. But they also have data about the impact of a ban on the use of territory that may be instructive. And then, finally, I would just make the offer to follow up with any, information that we can be a resource on. We have, again, a huge member company list. And if there's specific information you would like us to drill down on, I'm always happy to try to get that information for you or the committee.
What I'm asking for is independent information that talks about the actual loss, not the rate making, but the actual loss, and something that is independent. This is not independent. Trying to get to actually what you're saying is the case. And so that's what I'm asking for from you, not now, but for you to produce something that's independently validates your claim. That's what I'm asking for.
Okay, Senator, I'll work to find that source. I do think that the MIA would be a resource for loss cost data as well. So I can reach out to them as well to see what they might have on that front.
Appreciate it. Thank you.
Thank you. All right, that ends the testimony on that bill, and we're going next to Senate Bill 796, Senator Eckhart.
Thank you very much, Madam Chair and Mr. Vice Chair. It's good to be with Finance Committee this afternoon. Senator Addie Eckert for the record here with testimony for Senate Bill 796. This is the Maryland Office of Minority Health and Health Disparities and the Maryland Healthcare Commission reporting requirements. As you know, we spent a lot of time in the interim working on health disparities as we work together on the Senate President's Advisory Work Group for Equity and Inclusion. And this would essentially offer or state that the Office of Minority Health and Health Disparities, as they do their health disparities report card, to continue to do that, give us a report within the year, but then also work with the Maryland Healthcare Commission to identify not only physician composition throughout the state with regard to disparities, but also our whole healthcare workforce. And I think that's really important because we've looked at physicians before. We haven't looked at what I would call the interdisciplinary team, the whole spectrum. And I think it's important that we get some data on that. So then that we know, as you know, what kind of incentives, what kind of initiatives that we can move forward with to be able to deal with the health shortage that we have, not only health shortage, but healthcare disparity shortage, frame it that way. So this is a simple bill. I think it will get a lot of information for us. I think everybody's supportive because the Minority Health and Disparities Office is already doing this. We just wanted to expand it a little bit. So I urge your favorable consideration and ultimate passage of this initiative. And with that, I will say thank you very much. Good to be here.
Thank you, Senator Eckhart. Okay. All right, we're going next to Senator Lamb, Senate Bill 685. Senator, you have whatever time you need, and then Jesse Keese is your main proponent and will have the 5 minutes, and your other witnesses will have 2.5 minutes each.
Okay, thank you, Madam Chairwoman. If I could ask committee staff to bring up the slides for this bill, I'm happy to get started in the meantime. For the record, Clarence Lamb, Senator in District 12. This is Senate Bill 685. To those of you on the committee before, this is probably not an unfamiliar topic to you. This is the direct primary care bill as it comes forward this session. So next slide, please. So, just as a quick refresher, as you know, primary care is a critical component of our healthcare system. Obviously, research has shown that access to primary care certainly improves health outcomes for patients in our communities. But over the past decade or so, Maryland and much of the rest of the country, primary care has actually declined in usage. There's been now a movement for a new model for primary care called direct primary care that has recently emerged over the last couple of years. So direct primary care includes a contract between a physician and a patient that specifies payment and treatment terms and has a monthly fee instead of a traditional fee for service model. Next slide, please. The deficit of primary care physicians in America is rapidly becoming a crisis. By 2023 or 2033 rather, it's predicted that there could be a shortage of up to 555,000 primary care physicians, and this is due to a variety of factors. One of the large reasons is that primary care is one of the lowest paying specialties. This is really exacerbated by the fact that the average physician graduates from medical school with over $200,000 in debt and must complete a several year long residency program after medical school, where they also don't make relatively very much money. Primary care providers also cite high rates of burnout due to insurance-related paperwork and low amounts of time with patients as factors contributing to primary care decline. Next slide. So, we often get the question of how does direct primary care address this? If you can advance the slide, please. In direct primary care, patients pay physicians a monthly fee that ranges from $25 or to up to $125 a month, for example. This contract covers certain services like clinic visits and lab tests. The contracts typically also guarantee that these patients have closer access to their physicians, including more availability for same day and next day appointments and more frequent visits. Taken together, this allows physicians to spend more time with their patients, increasing the overall quality of care. It's also important to note that direct primary care is not insurance. Just to be clear, DPC is not insurance because the physicians do not bill insurance for their services. Instead, they provide them, the payment through a contract basis. Patients are asked to obtain catastrophic insurance to cover emergency room or hospitalization, as well as specialty care services, prescriptions, and other benefits. Next slide. Direct primary care is not a novel concept. There are 22 states that already have laws stating that direct primary care is not insurance and exempting direct primary care contracts from insurance-related requirements, which is one of the large aims of this bill. Other states have proposed laws or have had guidance released from their insurance commissioner on how to deal with direct primary care contracts. Next slide. So what SB 685 does is that it specifies that a direct primary care agreement is not considered health insurance and therefore would not be subject to provisions governing health insurance plans. It also prohibits direct primary care practices from billing insurers on a fee-for-service basis for the services provided through the contract. SB 685 also specifies certain contract requirements to protect direct primary care patients, including a clear declaration that direct primary care is not insurance. So it has to clearly state that up front. Finally, the bill authorizes the Health Education and Advocacy Unit of the Attorney General's Office to help consumers understand direct primary care contracts. Next slide. So the bill is important for a variety of reasons. First, if you can advance to the next slide. I think it's important to recognize that direct primary care is really a growing model of care, as you can see, as you saw from the previous slide, with many other states have introduced and opened this door open for direct primary care. This bill would create a clear definition of this model in legislation and provide some regulations on contract requirements. By removing direct primary care plans from health insurance regulations, we also may be able to make the direct primary care model more attractive to primary care providers, potentially increasing the number of these clinics in Maryland, and as well as increase the number of primary care providers and helping to address the provider shortage throughout the state. By improving access to primary care, we can also improve patient mortality and reduce the utilization of hospitals and emergency departments, ultimately lowering the cost of care for our state. And lastly, direct primary care models might also improve patient satisfaction and reduce physician burnout, as well as improve access to primary care in rural areas. Next slide. And so, this is just a quote from a recent publication in Health Affairs, which is a large medical journal that cites that under the direct primary care model, these providers can offer real preventive care, really addressing health and wellness and focus on the well-being of the patient, rather than the direct focus right now, mostly on patients that are already sick or have a condition or already ill. So I want to mention that we are working closely with the Maryland Insurance Administration to address some of the technical gaps in the bill language and ensure even greater consumer protections. We're still happy to have that conversation with them. And finally, next slide. We know that Maryland's healthcare system is obviously facing many challenges, including not only in this pandemic, but a shortage of primary care providers, and that potentially this direct primary care model is one that could help address some of these challenges. The bill clearly defines these agreements, includes regulations to protect patients. It may also make primary care more attractive to physicians by increasing the number of direct primary care practices. And lastly, direct primary care can help increase patient access to preventive care, as I mentioned earlier, resulting in better health outcomes. So for all of these reasons, would urge the committee to consider this carefully and hopefully arrive at a favorable report. Thank you for your time and consideration. I'll hand it back to the chair.
Thank you. Are there questions? Senator Battle.
Thank you, Madam. Thank you, Madam Chair. Senator Lamb, thank you for the bill. I have a few questions. So this isn't concierge care. This is something different. Direct primary care is different than concierge care, correct?
Yeah, it is very different. Concierge care, is different in that there are, additional benefits that are provided to these patients that go beyond what the direct primary care model has. Direct primary care is really it's really going back to the basics for primary care providers, where it covers things like preventive care, lab results, some basic diagnostics like x-rays and whatnot. Whereas, concierge care is you're paying a much larger lump sum that covers a lot more than just the kind of the back to basics model.
So what generally are the fees for direct primary care? Are they monthly fees? Are they dependent on service? What's the fee schedule look like?
Mostly monthly fees. I think based on our research and understanding, I think some other members of the panel can also describe this. It's, somewhere between $25 a month to maybe $125, $150 a month. And I think that's in pretty sharp contrast to some of the concierge clinics where you may be talking like $1,000 a month, but they also cover a lot more, right? And you have a much smaller patient pool for these providers that are engaging in concierge medicine.
But people would still need to have insurance other than direct primary care, correct? I mean, for hospitalizations or serious illnesses that occur, I mean, this couldn't be their only,
That's
their
correct.
only direct
Yes.
care. Okay.
Right. They still need to have insurance, particularly for, and some of these folks might go to like a high deductible health plan for instances where they end up in the emergency department, they have an accident, or for some reason they're hospitalized, that those plans will still cover, that. This is really just focused on the primary care outpatient kind of basis.
Thank you.
Let me ask, so if you had this direct primary care agreement, let's say for $100 a month, whenever there were a primary care need, and I guess some of it would be regularly scheduled because at reasonable intervals to make sure that the primary variables that ought to be under observation and documented, that all of that happens. Is that the case?
Yeah, I mean, I think it's really, and that's, what a good primary care provider would be doing. And it's really just kind of going back to those basics to allow the provider that wherewithal and means to be able to do that.
Okay, so what do you see as the population pool for which this would make a lot of sense?
That's a good question. I think, there are, for example, some employers that are trying to move toward a direct patient care model. And I think some of the other panelists would be able to speak to that too, where this model really works well for them to be able to get some of their employees in for, wellness checks or some urgent care type needs. And so, I think there's a means to be able to start there. But I think the panel can also speak to other practices that are looking at other ways to implement this.
Okay, sounds interesting. Okay, Senator Augustine.
Thank you, Madam Chair. Senator Lamb, the Office of the Attorney General came back with some questions, particularly around protections for against discrimination, how would these folks get to pick, or what, how does that work? Or how do they decide if they don't want a patient? Like, is it their call? Is it their decision, and who they choose to serve and who they don't choose to serve? And how does that fit within more of our public health concerns for the entire state of Maryland?
Yeah, I think those are some important considerations that we've been engaging with the Attorney General's office on with this bill. I think there are certain protections that are in place, and I think some of the other panelists can speak to this as well. But I think I certainly understand the concern that you could end up picking up a population that's healthier, and then leaving those that have additional comorbidities and conditions off of their roles. So I think if there are additional provisions that the Attorney General's office would make them feel more comfortable with this, we're happy to do that. And that's also one of the reasons that we included provisions in there to make very clear that their kind of consumer protection unit or office could work closely with these practices too, to make sure that patients that want to do this are clearly understand the terms of what they're signing up for here.
So would the ideal patient be maybe somebody who's just graduated high school or college and is relatively healthy but careful and wanting to have regular primary care? Or is it some other category of demographics?
I think it's a broad variety of different types of patients.
Okay, well, I think maybe we need to listen to your witnesses. So we're going next to James Keys.
Thank you, Madam Chair, Vice Chair Feldman, and other members of the committee. I really appreciate the opportunity to support Senator Lamb's bill, SB 685, which essentially clarifies that these DPC agreements are medical services and not health insurance. And to your question, we find people of all ages. The median age is 38, but it's especially good for people in older ages and Medicare populations who utilize a lot of care, particularly people who have multiple chronic conditions, because there are no copays and no deductibles and no barriers to getting the care that you want anytime that you want it. There's about 1,500 of these practices nationwide, more than a dozen here in Maryland. And the fee is paid, this is a monthly fee, typically paid directly by an individual or an employer, or even in some cases, a health plan. The fundamental value equation, I think as Senator Lamb well put it, is that the monthly fee does not pay for things like procedures that are done in an office. It pays for a long-standing personal relationship with a doctor of your choice. So the doctor is accountable to the patient, has more time to spend with a patient in that primary care setting, and there's less incentive to refer on to specialists or the hospital, because most docs in the confines of a 5-minute visit just don't have time to do that kind of diagnosis and treatment in that setting. But if a patient needs specialty care or hospitalization outside of the DPC agreement, that's where the insurance kicks in and bears the risk for that. So never has this been more important than now in the COVID pandemic. A Milliman study from last year, published for the Society of Actuaries, showed that in the 2 years prior to COVID, about 99% of direct primary care doctors were doing virtual consults or virtual visits. So when the pandemic hit, they didn't have to even flip a switch. They were already doing telehealth. They were already doing virtual visits. And these average monthly fees, I think, if you do Senator Lamb's math, are around $74 a month. So that's less than the price of an average cell phone bill. And more employers are willing to pick up the cost for that $74 a month. Boeing does, Johns Hopkins does, and you'll hear from them today. And what they're finding, a Harvard study showed that inpatient hospital admissions were reduced by as much as 37%. Maxar, which is a Gaithersburg satellite company, did a study a few years ago that shows patients who chose the DPC option instead of the regular PPO saved the company more than 20% off of the total cost of the healthcare benefit. That's the primary care and the insurance. How did they do that? They did it by preventing conditions, chronic conditions, by treating other conditions in a fixed cost primary care setting and virtually eliminating their administrative cost in primary care because nobody ever files any claims. It's paid for in this monthly fee. Patients love this, doctors love it. Senator Lamb will be happy to hear that there's now more than 30 states that have actually passed legislation or good solid regulations that do the same thing as this bill. And I would say there's at least 10, the way, depending on how you slice them, very important new patient protections in this bill that are not in place in law today. This bill requires that the agreement spell out all the services that are covered and state that the agreement is not insurance, but that patients still need insurance for issues outside of primary care. It says that the provider may not deny a patient because of any health condition. It prohibits this double dipping idea. So if you pay for something in this monthly fee, the provider or the patient can't go back and bill insurance for that. So there's no double dipping. And finally, the ultimate protection, it requires that all these providers be licensed under the Health Occupations Act. So if the AG or somebody needs to refer something about bad behavior by a doctor, it's the same as any other primary care practice. You refer to the medical board for review. So there's great regulations already in place that cover those things. If a practice fails to follow any of these procedures, then they are subject to regulation as an insurance entity outside of the confines of the boxes in this bill. So MIA would have the ability to come in if somebody's violating part of this and say, hey, we think what you're doing over here isn't just primary care, it's insurance, and we're going to regulate you as such. I think it's also important to point out that this bill harmonizes with a section in the Affordable Care Act that recognizes direct primary care as an important health reform and a part of the essential health benefits platform that's outside of insurance and yet provides a great value-based care delivery model for this country to migrate into, which we all think is a way to get away from the confines of fee-for-service. I really thank you for your time. I'm happy to answer any other questions and would urge you to give Senator Lamb's bill a favorable report and pass the bill.
It might be something I'd be interested in. I went home last weekend and got a letter that my primary care physician was moving out of state. And so where can I get a list of where would this persons with these agreements in Maryland have ads or something?
Well, at the Direct Primary Care Coalition, my organization, which represents a lot of these practices in most states in the nation, we have on our website, dpcare.org, a map function. You can simply go to that map, it's called the DPC Mapper, press on your locality and see who's there. So, there's and it gives you the phone number and the cell phone and the contact information for the practice. But I have to say, Senator, there's a panelist here, right here in Annapolis, who may have room in his panel if you're absolutely interested in that.
Okay, thank you. Are there other questions? Okay, we're going next then to Michael Friedman.
Madam Chair, hi, my name is Michael Friedman. I am a practicing physician here in Annapolis. If you want to swing by on your way home, I'm 2 or 3 minutes away. I am here asking for the support for Senator Lamb's bill 685 and asking that we clarify that what I'm doing as a primary care doctor is not health insurance. I practiced for over 15 years in a more traditional setting, and I was extremely busy, and I found that I really could not provide the kind of care that I wanted to provide to people. But at the same time, I'd also had run the Stanton Center, the outreach clinic there for 10 years, and we were able to give away 6,000 free visits a year when we were doing that. So I knew that healthcare delivery didn't have to be as complicated and as expensive as it is. And I felt like there just had to be a better way to do it. My practice, I opened about 7 years ago, a direct primary care. It's $49 a month and slightly more if you're older. Kids are $5 if they're under 18, and if they're 18 to 25, they're $10. So it's really affordable. It's definitely not concierge medicine, but the care you get is, probably somewhere equivalent to that. without too many of the bells and whistles that you don't need. What I'm able to do now as a direct primary care doctor is I can really be accessible to people. If you needed to text me, if you needed to email me, call me, do a virtual visit. We've been doing virtual visits since 2014. If you needed an in-person visit, whatever you need, we can manage it. We're open 11 hours a day. We're open on Saturdays. We can provide a very different kind of experience than a lot of people are used to with their primary care doctor. And by the fact that I can spend time with patients, it does make sense that the British Medical Journal was able to prove decreased hospitalizations by 35%, decreased ER visits, decreased surgeries by up to 82%. I mean, we really can spend the time to talk to people and help them get the right healthcare that they need. We advocate for them. And if their medications are expensive, we are able to find ways to get them less expensive. We have discounted labs as much as 90% discount. So we really feel that we can advocate for our patients and do what's necessary. And at the same time, it's not an elitist situation at all. We have patients that have Medicaid, Medicare, commercial insurance. We have people that have a deductible of $3,000 or $6,000. And for some people—
I hate to butt in, but we're going over time.
Oh, terribly sorry. I missed the little counter in the room.
Okay, thanks so much. Let's go next to Stephen Kravitz.
Good afternoon, Madam Chair and members of the committee. Thank you for the opportunity. My name is Steve Kravitz. I'm a physician, and I lead the primary care systems for Johns Hopkins. I, too, am here to testify in favor of Senate Bill 685, that direct primary care is not insurance. And I first want to share my gratitude to all of you for your fortitude during these difficult times. I want to share a story. This is a story of a patient, an employee of Johns Hopkins, who presented with stomach pain on a Friday afternoon. The primary care doctor didn't think it was an emergency, but was worried that it could evolve over the weekend. And in an effort to avoid using the emergency room if the symptoms progressed, the doc called the insurance company for prior authorization of an outpatient CAT scan. The DPC doc reached a utilization reviewer in this insurance company who would not give an immediate answer. They said to the DPC doc, "I'm sure you're busy and I'll get back to you." And the DPC doc said, "No, actually, I have the time now and it's my responsibility. I'd like to wait for your approval so I can manage this patient directly and avoid the ER." And so the utilization reviewer immediately escalated it to a medical director who also tried to delay the decision. And the DPC doc gave the same response. And because of his persistence, he was able to force a prior auth, gave the physician and the patient, and actually Hopkins, the self-insured employer, the benefit of care in the highest value way. So, this is an example of how we see DPC freeing the primary care doc and the team to deliver care in a non-traditional way. In addition to traditional primary care, DPC allows the team to better directly coordinate specialty care and outpatient procedures when appropriate, as I shared. So, as has been shared by my colleagues, DPC has been shown to improve health outcomes, quality, convenience and access, patient satisfaction, reduce unnecessary utilization, and increase joy in medicine. To the points earlier about some of the stresses in primary care in particular, this is a model that increases joy for everyone. These outcomes have been demonstrated in our Hopkins program, and particularly during COVID-19, when many struggled to re-engineer medicine, DPC agreements provided continuous care, as was alluded to earlier. At Hopkins, our first practice was opened in Howard County only because of the central location to our entire system. And indeed, our DPC patient panel, to the chair's question, is actually more sick than the average Hopkins employee. And this practice has within the top few overall highest scores at Hopkins in patient experience and quality. So evidence was cited nationally. There was just a recent February 17th New England Journal of Medicine article that cited direct primary care as a model upon which the future of primary care could be constructed. And at Hopkins, I oversee 200 primary care providers, and I too see DPC practice as the foundation for the future of our organization. So in summary, Hopkins has leaned into this model, and we hope that other large and small employers do as well. It is not an insurance plan, it's a delivery model that pairs to insurance. And so we humbly request your support.
I'd like to just read you a brief paragraph from the written testimony. That's a letter of concern from the Consumer Protection Division of the Office of the Attorney General, and see what you would say. The title of this paragraph, protect consumers in the individual market. The period of the pandemic and its aftermath is an especially bad time for patients to be placed at risk from less expensive, poorly regulated products that look like but are not health insurance, subject to federal and state law protections against non-performance, discrimination, insolvency, and other problems that historically have occurred with unregulated health insurance plans. I won't read the rest of the paragraph, but our members have received this. Could you comment on your take on that?
Is that directed to me, Madam Chair?
Yes, since they are one of you.
Well, I think this is a commonly shared view, but DPC programs are paired with insurance to assure that patients have access to wraparound services, the more expensive wraparound services like hospitalizations and specialty care. This is just bundled primary care, which is actually more accessible and more sustainable, truthfully, to all patients. Even low-income patients would be able to find an affordable option if they chose to have this membership model paired to their insurance.
Because they end with, again, that they're concerned about cheaper products that offer minimal coverage at increased risk of non-performance and insolvency. Are you more likely to go insolvent because you offer this kind of an agreement than if you worked in the more traditional vein?
If I can chime in, so I think that the statement that they're providing is not really it doesn't pertain to what we do or what we're talking about today, which is direct primary care. And that's the whole reason for the bill, is that we are not health insurance. We don't try to be a health insurance. We don't try to be a cheap giant health insurer. I'm just a doctor who's practicing differently than I used to practice with a different model. But I have all the same rules and regulations of patient abandonment. If I go out of business because I run out of money, I still have to figure out where to put everybody, the same as I would any other practice. So I don't think I'm any more at risk for being insolvent than any other primary care doctor.
Okay.
And
Chair, also, the letter assumes, it sounds to me like it assumes that this is replacing insurance, which is clearly not the case. And in fact, the contracts would have to say, this is not insurance, and you have to have insurance to go with it. And then that's in the bill, and it's a protection that isn't available today. So it's quite the opposite. You're getting boosted up primary care, not boosted down.
Okay, very good. Let's go next to Therese Hessler.
Good afternoon, Madam Chair, Vice Chair, and members of the committee. It's great to see everyone here today, and thanks to Senator Lamb for putting in this great bill. For the record, my name is Teresa Hessler, and I'm here representing the Foundation for Government Accountability, a group of public policy experts committed to sharing proven solutions to help communities and states. We are in support of Senate Bill 685, but with one simple amendment that is drawn from states that have had direct primary care laws for years. There are many benefits of direct healthcare arrangements, such as patients and providers having a higher quality relationship that enables better management of care, especially for those with special needs and chronic conditions. They can reduce avoidable healthcare spending over time, reduce wait times for patients, and reduce instances of surprise bills as costs are transparent upfront. States that have passed direct primary care laws in the past have started to update their laws to allow other kinds of providers and specialists to make such direct arrangements. Direct healthcare relationships are beneficial for a range of services, from dentistry to primary care, mental health counseling, or physical therapy, just to name a few examples. Direct healthcare providers are fully accountable to consumers and patients, and they are paid on their ability to achieve goals like enhancing outcomes and increasing patient satisfaction. Limiting direct healthcare arrangements to just primary care may be short-sighted, as it denies residents immediate access to innovative, high-quality care arrangements that deliver high-value, quality care for less. A simple amendment to remove the word primary in just a few sections of the bill as currently drafted would open the door to these innovative care models. We respectfully ask the committee to adopt the amendment and issue a favorable report of Senate Bill 685. Thank you.
All right, are there any questions of this witness? Okay, in that case, then we're going to Matthew Celentano, the League of Life and Health Insurance.
Thank you, Madam Chair, members of the Senate Finance Committee. I am Matt Celentano here today on behalf of the League of Life and Health Insurers in opposition to Senate Bill 685. This bill exempts direct primary care agreements from the regulatory authority. No regulator, no enforcement mechanism. We were talking about auto insurance before, and I sort of think that passing this bill would be like me saying to the General Assembly, you need to pass a law that the thing I drive myself around in from place to place is not a car. Therefore, if I go over the speed limit, I can't get a ticket or points on my license. If I go through a red light, I can't be fined. It's important to understand what direct primary care is and what it is not. The proponents have made it very clear that they say that it's not insurance, but they don't accept insurance either. The member fee covers outpatient, non-specialty services such as preventive services, basic lab services, and chronic disease management, all of which would be covered by a traditional insurance policy. And most of this would have no cost share anyway. It does not include prescription drugs, specialty care services, behavioral health and substance abuse services, hospitalization, or most other benefits provided by a medical insurance policy. The sponsors and proponents even say that you need an insurance policy to cover these other services. If they had just gotten a traditional health insurance policy, the preventive services that they tout would have been free under a normal insurance policy. It just doesn't make any sense to us. Also, it's capitated. In theory, you pay a fee, and that's unlimited access to the services provided. That's insurance. You can call it whatever you want to, but it's insurance. Once again, if the direct primary care agreement is providing services without regulatory authority, there's no enforcement, and therefore zero consumer protections that go along with the purchase of insurance. So it raises several questions to us. What happens if there's a dispute? Can the doctor set fees depending on your health status? This directly butts heads with the forward progress of the Affordable Care Act. There are no protections for a consumer if the doctor just decides to terminate the contract because you're using too many services. The contract could also be determined and they just leave and you are left without any place to go. We need appropriate regulatory oversight for a product you can call whatever you like, but it's insurance. And therefore, we respectfully request an unfavorable report on Senate Bill 685. Thank you for
Well, let me ask a couple of questions, Matthew. If in fact, well, we haven't seen the agreements, but if the agreement were to answer all those questions as to what is covered and what is not covered and so on, they've indicated that the agreements do, wouldn't that take away some of your concerns?
Some of the concerns would be alleviated if there was regulatory structure that would protect consumers, but that already exists. It's called the Maryland Insurance Administration, and that's why we think it's appropriate for them to be where they are.
Well, they have said they are not trying to be comprehensive medical care with all
Well, I will point out to one thing that was sort of concerned the proponents' testimony, Senator Kelly, and that was what they talked about double dipping, as then you would not be charged for a service if it was provided by the direct primary care agreement, and then you go to an insurance company to get another service, a follow-up service. Under this structure, there's no way for the insurance company to know that you had it in the first place, so they could double dip all they want to. If there's no regulatory scheme and no oversight, there's no control, and that's why we're concerned that this is insurance, and they just don't want to be called insurance, and they don't want somebody to make sure that they're doing it the right way.
All right, I'm trying not to be bullheaded, but let me just ask you something else. If I go to what was my primary care physician that just moved out of state, usually the insurance is going to cover everything. So often you've got a subsequent amount to pay. How is this different than that, except you would know in advance on a monthly basis or a quarterly basis what you're paying for whatever services you get for the things that they have said in a written contract they're going to cover under this agreement?
Well, Senator Kelly, they can operate today. They're operating in Maryland. The reason they want out of the insurance article is so there's no oversight on top of them. I would argue that what you're talking about is a fee on a certain basis. It's called an insurance premium. People are already paying for it. And those kinds of preventive services, most of which are covered by the Affordable Care Act already at no cost share. So we think that it's not appropriate for them to be anywhere but inside the insurance article with the proper consumer protections.
Well, usually there's something left over that the insurance doesn't pay for, and we do pay something in addition, except we don't know when it will be applicable and how much. And this way you get predictability.
I would say, Senator Kelly, that the kinds of services that the direct primary care agreements are trying to focus in on are the kinds of services that insurance companies are more than happy to pay for. Preventive services to take care of you now so we don't pay for a lot for it later.
But they usually tell you how many intervals in a period of time or in a year you can do certain things. If I need more service and I'm willing to accept this agreement that the doc is going to do whatever the categories of service are listed in the primary care agreement, then I've got that to lean on, haven't I? And wouldn't that stand up in a court of law if they abandoned me and didn't do that and I could document?
I'm not really quite sure how it would work, considering there's no authority once they come out of the insurance article now. And because it is capitated, to us, it is insurance. Now, Senator Kelly, I would be happy to try to find a policy. There are many, many hundreds of them that would fit your personal needs. Also, if you need a primary care physician, we will help you find one.
No, I'm just saying I like the idea is at least as something to explore. It does seem like a different.
Senator, I will agree with you that I think that it is appropriate to have all kinds of discussions about how to increase access to primary care. But I think that the framework is already there.
Okay, Senator Bidle.
Thank you, Madam Chair. So, Matthew, I guess where I can see a need for this is for someone who has one of these high deductible healthcare plans, which we know a lot of people that are buying individual healthcare, they're not part of a group. Some have $5,000 or $10,000 deductibles, so they don't have the advantage of certain preventative things being covered until they meet their deductible. So wouldn't this be helpful for someone to have a regular primary care physician? And then, of course, if they had to be hospitalized, they'd have to go, handle that large deductible. I can see where this can make a lot of sense for that.
I understand where you'd be coming from, Senator Bidle, and I think that the high deductible health plans are something that have become more prevalent in the past couple of years. A lot of reason is because of the requirements of the Affordable Care Act. Also because it is expensive because healthcare is expensive. Hospitalizations, prescription drugs, all these things have exploded over the past couple of years. But at the very basics of the Affordable Care Act and the requirements that come along with it, including the preventive services, the kind of things that these kinds of agreements want to approach, are free. There's no cost share involved, including your annual visits, some of the labs, preventive services, some of the colorectal cancer screening things that you've passed in the past couple of years, diabetes test strips. The General Assembly has been really proactive on making sure that those preventive services are covered at no cost share to consumers. So we think this is just an additional way to get around the regulatory authority that protects consumers.
Thank you.
Okay, any other questions? Okay, well, that ends testimony on this bill. Thank you very much. All right, we're going next to Senator Zucker, 719. Senator, you have the time that you need to lay out your bill with all the parameters, and your lead proponent is Senator Augustine. So that person has 5 minutes and your other witnesses will have 2.5 each.
Thank you very much, Madam Chair, Mr. Vice Chair, distinguished members of the Senate Finance Committee. For the record, Craig Zucker here in support of Senate Bill 719. I couldn't think of many better first witnesses than Senator Augustine. He and I have been really tag teaming the issue around this bill with mental health together. And I just wanted to personally thank him for his leadership and and counsel, quite frankly, on trying to make what I'm about to explain reality. Also wanted to thank Clinton Askew from 211 and the National Alliance on Mental Illness. So, Madam Chair, colleagues, what we've seen through the global pandemic is the impact it's had on people's physical health, but some of the things that sometimes go unnoticed is the impact that it has on people's mental health. I would say, and Senator Augustine and I've talked about this many times, and that's why we're partnering with on this, is, we've seen people close to us, both that are both private and public figures, lose people dear to them, and we all know we're all impacted by the pandemic. It's all affected our mental health. Some of us be able to compensate better than others. So what this bill does is this bill will allow the 211 service, and Quentin is on the Zoom call. But what it'll allow is people to proactively opt in for a 211 call service where 211 will check in on them. And if they need, they'll be connected to a mental health provider. What we've seen through this pandemic is just staggering amounts of folks that are calling, asking for mental health assistance. Quentin will probably tell you that in 211 itself, calls have gone up 61% if you compare this quarter to last quarter. When I've talked about this publicly, I've said that, there's never enough money that we can put toward mental health, but we still need to put money toward it. There's never enough services we can provide, but we still need to do all we can to provide it. So this we believe is legislation, and I believe there's no opposition to it, that will give people the opportunity to leverage and utilize these mental health services before they reach a crisis point. This is to catch them earlier. This is something that we can do as public servants. And before I turn it over to my good friend, Senator Augustine, there's two amendments for your consideration. One is based on our communication with 211. There's no reason to have an effective date of October. They'd be ready to go. So we're making it July 1st. And the other effective date is, even though the fiscal note basically says there's no fiscal note, doing what was right sometimes has a cost. So we don't want to limit the opportunity of the governor in the future to include money in the budget if he wishes. So there's an amendment that should be in your file that says the governor may add money into the budget if it's required. And with that, I'd be happy to turn it over to my good friend, Senator Augustine.
Thank you. Senator Augustine.
Thank you, Chair Kelly and members of the committee. I'm Senator Augustine here in strong support, Senate Bill 719. As Senator Zucker mentioned, colleagues, this pandemic has brought and exacerbated unbelievable amounts of challenges to our behavioral health. The data shows significant increases in incidences of behavioral health conditions among Marylanders and utilization of services. But we know it is just the tip of the iceberg of concern. Suicide is up at an alarming rate. I am all for being proactive and stopping tragedy and poor behavioral health outcomes before they manifest. And this bill does just that. It empowers people who are open to receiving help with their behavioral health challenge to get it proactively through our tremendous behavioral health resource 211 to triage them to mental health providers. Senator Kramer, I just got to tell you that Senator Zucker made the connection between the benefits of our proactive senior call check program, our current suicide crisis, and our behavioral health crisis resource of 211 to bring all that together for this. And that was just absolutely genius. Now, so I am just grateful that Senator Zucker included me in the process of bringing it all to our body, along with the stakeholders who you will hear from next, who are all in agreement to bring this to fruition. I strongly urge a favorable report.
Thank you. Mr. Sponsor, let me just ask you this. How much human capital, how much infrastructure will you need if this really were a statewide program and people call 211 to get it. Are we sure?
Yeah, so we not only I am absolutely 100% positive we can get this done because and Madam Chair, Mr. Askew is going to speak on that. He's already got the infrastructure. His team will be taking the lead on it. They have crisis centers that they'll be able to plug people into. And one of the reasons why it's important that Mr. Askew's on here is not only because they'd be helping to take the lead on this, but he can give you sort of the nuts and bolts. But the infrastructure already there, and we'll be utilizing the staff, the nonprofit staff that he has that are mental health specialists, but they already have the infrastructure for it. We might need to provide more resources down the road, but they are ready to go. And that's why we're changing the effective date from October to July. But I'm sure when Mr. Askew speaks, he will either tell me if I'm wrong or right, but I think I'm right, Mr. Askew.
Okay. Any other questions? Okay. All right. We're going next then to Quentin Askew, 211 Maryland E.
Thank you. Good afternoon, Madam Chair, Vice Chair, and honorable members of this committee. Also, thank you again, Senator Zucker and Augustine, for your leadership with this topic. My name is Quentin Askew, President and CEO of 211 Maryland, here in support of Senate Bill 719, Maryland Department of Health Mental Health Services phone call program. This proposed legislation does several things, including providing proactive support to reduce an individual's crisis, connecting to a caring, trained crisis specialist when needed, and improving access with a direct connection to behavioral health services. Marylanders who choose to opt into this service for a follow-up call will be able to access this service in 3 particular ways. So one is through SMS text, easily text the created keyword to 898211. Online, there'll be an easily automated registration form that someone can connect with, as well as simply dialing 211 and connect to an automated callback feature. Marylanders who opt in and supported by one of our call center network crisis specialists, so who will assess their needs and really link to the appropriate resource. Our network of call centers has extensive experience in mental health first aid and trauma-informed care. They are nationally accredited through American Association of Suicidology, Alliance of Information and Referral Systems, CARF accreditation, the International Council for Helplines, and support the National Suicide Prevention Lifeline. And nationally, 211 is recognized as the most comprehensive source of services. So since the pandemic, I think you all know that 211 Maryland has been the state's connector to health and human services for crisis supports. Our crisis calls and mental health supports has almost tripled since the pandemic, especially with our 211 Press One crisis line. During these difficult times, it's important that Marylanders know that they're not alone and help is available when needed. This legislation provides a lifeline and really an empathetic voice to those who are in need. And as someone who has lost a loved one recently to suicide and understand the toll that it takes on the family, I urge you to consider a positive statewide impact that this legislation will have. I appreciate the opportunity to provide this testimony and welcome any questions that you all may have.
Thank you. What would you say would be the typical amount of time to handle an individual call? Would it be 5 minutes or 15 minutes or what? And how much staff would you need 24 hours a day in order to, to really be active and supportive all day long?
Typically, we would say generally between 5 to 7, maybe 8 minutes for a crisis call, really depending upon the crisis. If the person is in immediate crisis and needs immediate help, then that person will be immediately connected to one of our 911 partners or a mobile crisis team. If this is someone who's sort of maybe having a mental health crisis and needs someone to speak with for us to be able to understand and de-escalate the situation, that could be between 5 to 7 minutes just to be able to understand what the needs are and to ensure that this person is connected to a particular resource. Our implementation of this particular program will be able to provide us some additional support for staffing. Currently, our call centers are already 24-hour staffed with crisis specialists that are currently supporting the state's work. Our goal is really to ensure that this program is implemented as best as it can. That will require us to get some additional staff to help support the work that we're doing. Most of this will be through technology, in which our infrastructure that we currently have set up through our phone, our IVR systems, our texting platform that we currently have set up. So additional funding will just be able to help support bringing in additional staffing support that will be able to help our crisis call centers, who are now, of course, answering calls related to the pandemic as well as other emergency supports.
So the number of people that you're able to help or that you project you would concurrently at during any hour?
Yes, could be a particular any hour. Generally, some of our crisis calls are generally within the later hours between midnight and 6 a.m. We've seen since the pandemic, we've been having almost upwards of 45,000 calls per day coming through our call centers. Last year, we answered over 400,000 calls for the year. About 50 to 60,000 of those calls were related to mental health, suicide, and emergency crisis needs. But we have 5 particular crisis call centers now that are 24/7, 365 that are currently supporting our statewide crisis work.
Okay, are there any other questions for this very informative witness?
Senator Benson.
Senator Benson.
Yes, thank you very much. I just wanted to find out if this is, what is is this a pilot program or is this something that's designed for the entire state? Is it a pilot
state.
program? And the
Entire
other thing
state.
is, how would you get your financial resources to get started? How is it funded?
Sure. So one is, I guess let me, so one is, it would be statewide. This is not a pilot. This would be, if it's the wisdom of the General Assembly and it becomes law, then it would be a full-fledged program. And I couldn't think of a better timing for it where people are needing mental health assistance. So I guess,
I agree with that.
Mr. Askew, let me just touch on the budget piece real quick, and then you already have a budget structure. I could just say off the bat that there's money available. Mr. Askew and Senator Augustine and I've spoken offline. There's money available, quite frankly, if he doesn't have the resources right now to get off the ground. If there's additional, which I think he does, but if there's additional funding that's required, there's a direct link to this mental health services and the relief package that the Senate and the House just passed. That's law. So there's money there. We can directly tie the relief package that we did to having them in this next fiscal year or this current fiscal year get set up if there's additional resources that they need. And then for ongoing, if they're not able to handle it with their ongoing resources, then that's why we're having the amendment that the governor can add money in the future.
Thank you. Are there other questions? Okay. Very good.
I think, I don't know if Senator
We're
Benson
going to
was finished.
That
Cyphers.
did. Thank you.
Okay. All right. Mariah Cyphers of Nami, Maryland.
Good afternoon, Chair Kelly, Vice Chair Feldman, and members of the committee. I'm Maura Cyphers with Compass Government Relations here on behalf of the National Alliance on Mental Illness. NAMI Maryland strongly supports this legislation. And just to help provide a little additional context about what's been going on this past year, NAMI runs a statewide organizational helpline and calls to their helpline our way up. And it's not just isolation, depression, anxiety, and questions about where to get services. The pandemic has really compounded everything. And if you're an individual living with mental illness, unemployment, housing issues, hunger issues present incredible obstacles to wellness. And so even NAMI has had to stretch in terms of the services they provide and what resource connection they can do. So a service where folks can opt in and say, I'm not feeling great, I'm not doing well. I could use in a little check-in during a pandemic and normally is wonderful and a necessity. And if you're not familiar with 211 and in particular, the amazing work of Quentin Askew and his team, it's an incredible service connector. 211 Press One is of course for mental health, but they're flexing to work on COVID and vaccine distributions, and their reach is really incredible. I bet as a mom, if I needed, I could get connected to a diaper bank, aging and employment services, government and legal help. I think he left, but Mr. Celentano could probably get a cover for his pool table. No, I'm just kidding. But We know different age groups prefer different modalities when it comes to communication. And one thing NAMI wants to make sure is that text communication is an option. So I'd urge the committee to ensure different modes of communication work. And I think sounds like that's a possibility. So in closing, part of what NAMI does is run free support groups, education and training for individuals with mental illness in every county across Maryland. During the pandemic, they've also worked with the Behavioral Health Administration to develop COVID Connect, which is a place for health resources for COVID survivors. They're putting on webinars for first responders. And I know that this is a service that they would love to share and provide to all of the populations they work with. So thank you to Senator Zucker for bringing this bill and for Senator Augustine for always being such a strong ally. And NAMI Maryland asks for a favorable report on this bill. Thank you.
Thank you. Are there any questions?
Madam Chair, I just want to, can I associate my remarks or Senator Augustine's remarks for thanking Senator Kramer for all of his work in the past around these type of issues, and especially the opt-in program around seniors. I think it's made a big difference.
Fantastic. All right, we're going next to Emily Allen with Mental Health Association of Maryland. Is she? You got to unmute.
Her audio is not working. She is unmuted.
Your audio is not working. We can't hear you. Your audio. No. It looked initially like it was unlocked, but we couldn't hear you. Now you have locked it. Okay, try it now. No, I don't hear you. Well, I tell you what, all of these are very reputable organizations that are testifying in favor of this bill. And NAMI and the Mental Health Association. We've got written testimony from AARP and from Maryland Rural Health Association. There's nobody against the bill.
Madam, can you hear me now?
Okay, I can hear you now.
Well, to my phone. I'll try to figure out what's going on with my laptop.
Okay.
Good afternoon, Madam Chair, Vice Chair, members of the committee. My name is Emily Allen. I'm the Public Policy Associate of the Mental Health Association of Maryland here in support of this bill. So this bill would provide a vital resource for our Marylanders who have been struggling with their mental health, both long-term and as a result of COVID-19. Even before the pandemic began, studies were showing us that youth mental health was worsening and the prevalence of mental illness and suicidal ideation among adults was increasing. During the pandemic, 40% of adults in the United States had started to report symptoms of anxiety or of a depressive disorder, which is up from 10% in 2019. In Maryland, rates of anxiety and depression ranged from 25% to 40% throughout the pandemic, and many are reporting difficulty sleeping, increases in alcohol consumption or substance use, and worsening chronic conditions due to the worry and stress that resulted from the pandemic. Adults have faced significant loss of income, and research tells us that job loss is associated with worsened mental health issues. And then there's all that we've asked of our essential workers over the past year. This problem is not going to go away as the pandemic subsides. There are new studies in the United States that show us that those who were sick with COVID-19 had a significant chance of developing a psychiatric disorder after they recovered. And studies from other countries, including the UK and Ecuador, have seen increased rates of mental health issues following a COVID-19 diagnosis, including depression, anxiety, and PTSD. Smaller scale programs similar to what this bill would establish already exist throughout the state. The senator has mentioned the one we use for the elder community already, but there's also the American Legion that does buddy checks for their veterans with mental health concerns. Frederick County's Mental Health Association has calls to their seniors, and Baltimore Neighbors Network provides emotional support to Baltimore's residents. This program would fill in the gaps for Maryland citizens that are struggling with their mental health that can't already be served by those other programs. And with that, we urge a favorable report.
Thank you very much. Are there any questions for this witness? Well, I see no unfavorables. And all of the favorables seem very enthusiastic and seem quite convincing. So we ought to soon be on the way with this good bill. Thank you very much. All right, we're going next to Senate Bill 729, Senator Feldman.
Thank you, Madam Chair.
Okay.
Let me just first start by saying that there is no opposition to the bill. Okay, I'll just start there for that one. But so as many of you know, I chair a commission with Delegate Pena-Melnick called the Maryland Health Insurance Coverage Protection Commission. And we've done it, I think, in this committee, with the help of that particular commission, we've done, I think, a fantastic job the last few years in terms of stabilizing our individual insurance market, getting our uninsured numbers down as a state. You know, 6-7 years ago, we were at 12% uninsured. Madam Chair, members of the committee, we're down to 6%. And many of you know, the last 3 years, we've actually seen a reduction in the premiums in the individual insurance market. One of the best performances really in the entire United States, largely due to the creation of the largest state reinsurance program in the country. And that all started here in the Senate Finance Committee. And let me just say, 31.5% reduction in premiums in the individual market just since 2018. Again, most of that work happened right here in this committee. But the commission, and I think this committee, we continue to have to look at some new ways to bring down overall premiums in that marketplace and actually get more Marylanders health insurance. And so one of the most basic tenets of health insurance, obviously, is you've got to keep your young, healthy folks in the insurance risk pool. You know, it's really pretty basic, because if not, that risk pool, you're stuck with an older, sicker population, and everybody's paying more. And that's kind of, you know, basic stuff. So when the Affordable Care Act mandate was eliminated a few years ago, we started to see a bit of an uptick with young, healthy folks no longer needing or being mandated to have health insurance to peel off a little bit and over the last few years. So we've been stuck at that 6% uninsured number. Again, we went from 12 to 6 and we wanted to go further, but we've been stuck for some time at that 6% number. So one thing we started to look at in the commission a few years ago was something that's been in place in Massachusetts, which, by the way, has the least expensive health insurance in the country and the lowest rate of only 3% of their population has no health insurance. And also a program in 5 other states similar to what they have in Massachusetts. And the idea here is to have a targeted state-based subsidy directed specifically to those young, healthy folks who fall above eligibility for Medicaid, but are healthy, young, and we want to try to get them into the risk pool. That's kind of the thinking. And so, first of all, it's good for them. We can give them a little help to get them in. It's good for them because now they have health insurance, but it's also good for everybody else in the risk pool because their premiums will also come down. And so last year in the committee, we passed a bill that I brought directing the Maryland Health Benefit Exchange to actually submit a report on this topic with some recommendations, which they did. And then basically over the last year, they worked with the Maryland Health Benefit Exchange, worked with the MIA on this topic, and they had a work group and they hired and commissioned an actuarial analysis to be done on this very specific topic of a state-based subsidy program. Again, they had a stakeholder work group, and then they submitted an actual report to the legislature on their findings. And here's what they found, Madam Chair, pretty interesting. They found that young adults in Maryland between 18 and 34 are the largest group of uninsured Marylanders by age, accounting for 43% of our uninsured population, that 18 to 34 group. And a lot of those folks really fall within that 138% above poverty, federal poverty level. So they're in that tough spot. They're not eligible for Medicaid, but you want to get them into the risk pool. So that's the target group that was really focused on. And so what this actuarial analysis found was that the young adult subsidy would it would increase the young adult enrollment, further stabilize the individual market, again, by bringing healthier than average people into the market, which again, in turn, reduces premiums for everybody else in that risk pool. And here's also a statistic that I think some of you might find interesting. When they took a closer look at who doesn't have health insurance, Black, Hispanic young adults are 2 to 3 times more likely to be uninsured than white young adults. So making coverage more affordable for this group also addresses the health equity issue that we've also been discussing in this committee in the General Assembly of this session. So Madam Chair, members of the committee, so in order to strengthen that individual market, mitigate the inequities in health insurance coverage, that stakeholder work group I mentioned from the exchange unanimously recommended that the exchange target a new state subsidy at young adults. The funding would come from a small portion of our reinsurance fund. So we're not talking about any new revenue, no new taxes. We're just taking a portion of what already exists in the reinsurance fund and deploying it in this very targeted way. And then the Health Commission that I chair with Delegate Pena-Melnick, we also followed suit by recommending, and we put this in our year-end report, establishing a state-based individual subsidy focused on young adults, but we did suggest that it should be a pilot project. Let's not just do it. Let's test this model out. And so that's what 729 does. It acts on those recommendations by authorizing the exchange to, implement a young adult subsidy pilot program in 2022 and 2023. The target group will be ages 18 to 41, and it's 133% to 400% of the federal poverty level. That's the economic group we're trying to hit. Again, above the Medicaid, but in that next spot right there. And the program would be funded in the bill as written with $10 million in subsidies out of our reinsurance fund for years 22 and 23. According to Exchange, and they'll be testifying, that will have very little impact on the reinsurance fund. There's like $445 million there for over the next couple of years, but you can ask them about that. The pilot also would allow us to gather some more data or gather data generally on the impact of this, and that'll allow us to see if we want to go forward and expand on this idea in 2023 and beyond, Madam Chair. So the only amendment that I have offered, it alters, there's a typo when I mentioned 133% to 400%. The bill has a typo and it's got like 140. So this corrects that typo so to correct that. And then it really generally just conforms this bill to to the bill in the House. The HGO subcommittee, I think just today, voted this bill out, and they may have had maybe one additional amendment. I haven't had time to look at it. So again, no opposition. With that, Madam Chair, I'd ask for a favorable on Senate Bill 721. And we have folks from the exchange behind me to talk a little bit about the work of that the group, et cetera. But that's basically what the bill does.
Thank you very much. All right, we're going next to your lead proponent, Joanna Fabian Marks of the Maryland Health Benefit Exchange. We got an expert.
Thank you, Madam Chair, Vice Chair, and members of the committee for this opportunity to testify in favor of Senate Bill 729. I'm Johanna Fabian Marks, Director of Policy at the Maryland Health Benefit Exchange, and the Vice Chair did an excellent job describing the bill, so I will try not to repeat the information that he shared. But as he mentioned, over the last several years, Maryland has taken significant steps to stabilize the individual market, including implementing the reinsurance program, which reduced premiums by nearly a third since 2018, as was noted. And those efforts have really resulted positively. The individual market has grown by 9% during the most recent open enrollment period to nearly 235,000 individuals. But despite this achievement, we've got about an equal number of Marylanders who are eligible to enroll in private health insurance, but who are still uninsured. And as has been noted, young adults are the largest group of uninsured. In 2019, we surveyed uninsured young adults, and about 70% told us that they would like insurance, but find it difficult to afford. So we heard kind of loud and clear that affordability is, the issue that's holding them back. As was mentioned, we've done significant work over the last year, including working with the MIA on an actuarial analysis that we commissioned, convening a stakeholder work group, and submitting a report to the legislature. The actuarial analysis projected that providing state subsidies to young adults would increase enrollment, further stabilize the market, and benefit everyone by bringing down premiums for all enrollees. Our stakeholder work group reviewed the actuarial modeling and considered inequities in the current market, including, as was noted, that Black and Hispanic young adults are 2 to 3 times more likely to be uninsured than white young adults in Maryland. And also that the state reinsurance program, which has done such a remarkable job at reducing premiums, primarily benefits those with higher incomes, so not our young adult target population under this proposal. As was noted, Senate Bill 729 acts on these recommendations by authorizing the exchange to implement a young adult subsidy pilot program in 2022 and 23. And that timeline aligns with our reinsurance waiver, and I can elaborate further on the benefits of that, but it would be timely in terms of data collection on the impact of the program. And I'll just briefly address a few issues related to implementation before I conclude. First, funding. As was noted, funding would come from state funds currently dedicated to reinsurance, so no new revenue is required. And we have, we believe, sufficient revenue to implement the pilot without affecting reinsurance. You may have heard also that Congress is proposing to expand federal subsidies for 2021 and 2022. That congressional proposal would improve affordability, but it would still be designed to favor older adults. So as a result, a young adult subsidy would still be beneficial and could be designed to work in concert with any federal changes. And lastly, regarding implementation, the bill proposes implementing the pilot starting in January 2022. And I just wanted to let you know that at the exchange, we're prepared to meet that timeline. We welcome the chance to get assistance to young adults out the door as soon as possible. And as I mentioned, that aligns with our reinsurance waiver, which has some benefits. So in conclusion, the pilot program would target our largest group of uninsured, address inequities in the market, and provide timely data to inform a decision about whether it makes sense to continue or expand the program. So I'd like to thank again the Vice Chair for introducing this bill and the committee for your work, which has helped to make Maryland a national leader in making healthcare affordable and accessible. A favorable report on Senate Bill 729.
Okay, thank you. Senator Reedy.
Thank you, Madam Chair. You don't know how, Senator Feldman, you don't know how happy I am to have it be 18 to 40 because it means I'm still a young adult, which is I'm just under the wire there. Ms. Fabian Marks, thanks for your testimony. How many of, trying to understand the scope of this problem, because obviously people can stay on their parents' insurance till they're 26. That doesn't mean, of course, that all people have parents by the time they're 26 or they have insurance, but how much of this is a problem of people in their 30s up through 33, 34 and higher versus people in their 19 to, I'm just curious of the scope of the issue, 19 to 23 versus like 19 to 25 years old.
We did look at that. I don't have the numbers at my fingertips, but I'd be happy to share them. We did see higher rates of uninsured once you get to the 20, kind of the over 26 population where they're no longer eligible to be on their parents' plan. So we do see a big jump in uninsured after folks are aging off their parents, but there were certainly still thousands of uninsured young adults under age 26. As you mentioned, there are a number of reasons why they might not have parents' insurance.
And with this bill, so with this funding, it would take us to where somebody that's, I'm looking at the fiscal notes, 133 to 400% or so of the poverty line would be able to get a full subsidy, or as you get closer to that 400%, the subsidy drops, or?
Yeah, the modeling that we did was designed to phase out the subsidy as you get closer to the end of the age eligibility and as you get closer to 400%. So younger and lower income folks would be eligible for the highest subsidy amount.
And Senator Feldman, I guess my last question, if I could ask you, is or either one of you can answer this question. There's a cliff effect. The cliff effect after they turn 40. Is there? Are we able to smooth out a cliff effect, or like what? I know this is a pilot, so I understand we're not trying to map everything out, but I'm just curious, like what your thoughts are about that.
Yeah, that's a great, actually, Joanna, why don't you take it? That's a great question, because you get people in and they're doing all this stuff, but no, Joanna, why don't you take a crack at that?
Sure. So yeah, we modeled a few designs. One where the subsidy would be fairly generous and then kind of abruptly end at 40, so you'd experience that cliff. But we also modeled designs where it would phase out gradually. So once you get to age 40 and you're no longer eligible, it's a gentle kind of transition to just being eligible for the federal subsidy, and you wouldn't really notice it. And that's what our work group recommended, is something along those lines.
And Madam Chair, I know I said the last question, but I have one more quick one, and I appreciate the indulgence. So Senator Feldman, you're taking $5 million from the reinsurance fund, and I wasn't on the committee when we were doing a lot of that. I remember some of it, but that's obviously it's like you said it's about $445 million in the fund,
Well,
right?
I think the first question I had was, and I should also note, that the governor in his proposed budget, in fact, I think that's the subject of some hearings today, the governor took $100 million, and Joanna, you can speak to this, some other amount of money from some of the pot of money that, could come into play here out of that reinsurance dollar fund. But I asked that very question. I want to make sure that whatever we're doing, this 5 million, 10 million number has no material impact on all the success we've been doing here, with the reinsurance and stabilizing our market. So Joanna, I think, answer that, a specific question.
Well, because also, once we start something, if it works, we're going to have to find the money.
Well, here's the thing is, okay, let me just say, she waiver, and I know you're not that familiar. This reinsurance waiver is only till 2023. So if we want to do reinsurance or a lot of other stuff, past 2023, we as a committee are going to have to figure out other stuff. So this idea of we're beginning something, this will give us some data to work with when we go and we're trying to figure out what are we going to do past 2023. So I think this is helpful timing wise to make us informed about where we go past 2023. And Joanna, Madam Chair, if she could add something to this pretty important question that Senator Reedy asked.
Sure.
Yeah, so as the vice chair noted, the governor has proposed to take $100 million a year out of the reinsurance fund to support Medicaid. And I think there's been some conversations about how long that might go forward, how many years that would happen for. But I think given the large amount that we've accrued to date, the $445 million that Senator Feldman noted, and the scope of the pilot program, which this bill proposes at $10 million a year, and the House is looking at an amendment to increase that to allow the exchange to spend up to $20 million a year. I think at either level, I'm not concerned about our ability to support the reinsurance program through the end of the waiver period.
Okay, thank you. All right, we're going now to Reverend Lee Hudson, the Delaware, Maryland Senate. Is this the event?
Madam Chair and members.
They tell me I'm skipping somebody. All right, let me go instead to Stephanie Clapper, the Maryland Citizens Health Initiative. I'll get back to you.
Which do you
want?
All right,
Reverend Hudson. Thank you, Madam Chair and members of the committee for this opportunity to testify in support of Senate Bill 729 on behalf of the Maryland Citizens Health Initiative. And thank you especially to Vice Chair Feldman for sponsoring this very important legislation. Thanks to your committee's leadership, Maryland truly is a leader in the nation in connecting residents with quality, affordable health coverage through innovative programs like the Maryland Easy Enrollment Health Insurance Program. However, as you've heard, hundreds of thousands of Marylanders remain uninsured, with young adults making up the largest age group that is uninsured. And within this age group, there are large racial and ethnic disparities in coverage, making this a health equity issue. The COVID-19 pandemic is ravaging the health and economic well-being of Black and Brown communities, which adds to the urgency of resolving these inequities. Help can't come soon enough. State-based subsidies will help young adults access much-needed health coverage while also stretching Maryland's dollars to help the highest number of Marylanders possible, as well as stabilizing the individual market by bringing in more young, healthy people. The pilot that would be created by this legislation is the result of years of thoughtful analysis and discussion by stakeholders on how to make coverage more affordable for Marylanders. The need is great, and I advocate for as quick an implementation as feasible, both so that young adults who would benefit from this pilot can start getting the coverage they urgently need, and like Senator Feldman said, so that we can collect useful data to help guide Maryland in addressing affordability moving forward starting in 2023 or after 2023. 5 other states have already created or passed legislation to create their own state subsidies programs, and I hope that Maryland will be the next with the passage of this bill. As Ms. Fabian Marks mentioned, the Insurance and Pharmaceuticals HGO Subcommittee just passed the cross-filed bill, House Bill 780, with an amendment by Delegate Kerr that would authorize the exchange to spend up to $20 million per year on the pilot. This would bring the amount that could be used during the pilot program closer to what the individual subsidies work group that I served on recommended in its report. And I think that it's a really good way to help the greatest number of people. It's a great amendment, and I hope that the Finance Committee will consider doing the same thing. So thank you for your consideration, and I urge a favorable report on Senate Bill 729.
Thank you very much. Okay, we'll now go to Reverend Lee Hudson.
Thank you very much, Madam Chair, Senator Feldman, for bringing this bill to us. My name is Lee Hudson. I'm assistant to Bishop Bill Gohl of the Delaware, Maryland Synod Evangelical Lutheran Church in America. We're a faith community in Maryland in 3 different synods with congregations from Ocean City to Red House, Maryland. And we've been on this pilgrimage to ensure the uninsured with you, members of this committee and its predecessors, and the General Assembly, and our advocate allies for the last 20 years. We thank you for all that you have done. We support SB 729 because it does expand access to healthcare to more people who don't currently have it. And we're especially happy to note with the others who testified that this is going to be a benefit for health equity in Maryland. I can add that for the first time in the years that I've done this, Lutherans from our faith community called me and asked me subsequently to the racial protest this summer, what are we doing about healthcare equity in the state of Maryland? So it's something that's risen in importance among our constituency. We like this bill. In general, we are advocates for generous subsidies on the exchange, and we concur with the amendments that we have become aware of and ask your favorable report. Thank you very much.
Thank you. Are there any questions for Reverend Hudson?
Madam Chair, I think you may have skipped, there was one witness.
I haven't finished. I'm going.
Okay, gotcha.
I'm going to call Mutt Bain from the Maryland Public Health Association.
Hi, my name is Mukta Bain. Thank you so much for this opportunity. I do support Senate Bill 729. This will help me and also other people with similar situation in Maryland. So back in August, I got a job as a contact tracer at Baltimore County Department of Health. They did not provide me and many others with health insurance because we were hired as a contractor. So because I was making little money, I'm not eligible for Medicaid, but then, so I went to Maryland Health Connection to see my options because I'm not eligible for Medicaid. The option that was provided for substance, either the premium or the deductible are too high for me. So I was worried because I do have medication that I have to take every single day and also therapy session every 2 weeks. I was scared, and I'm still scared right now because clearly I won't be qualified for health insurance if this bill does not pass. Because of COVID-19, the Medicaid was expanded for me, but I'm not sure for how long. So sooner or later, I do have to decide either should I pay my rent or my health coverage. I strongly do believe that this bill will be very positive outcomes. And please think about us and our health and pass the bill. Thank you.
Thank you very much. Are there any questions for either of the last two speakers? All right, then that ends the testimony on a bill that seems very much needed, and they've got a source of funding it, and we need to not waste what the committee has already done good work on, and we ought to do it for moral and righteous reasons also. Okay, thank you. We're going next to Senator Vital, Senate Bill 748. Senator, you know the drill. You've got as much time as you need to lay out the parameters of your bill. And then your lead proponent, Craig Baim, has 5 minutes. Everyone else will get 2.5.
Thank you, Chairman Kelly, Vice Chair Feldman, and members of the committee. Thank you for the opportunity to present Senate Bill 748, Public Health State Designated Exchange, Clinical Information. For the record, this is Senator Pam Vital. The purpose of this bill is to further enhance the data available through our state's health information exchange to support public health efforts and healthcare providers. During the COVID-19 pandemic and for many years before, clinicians have relied on HIE for crucial patient information. They use it to view prescription drugs, to combat the opioid epidemic, to see lab results ordered by other providers, and to see recent hospital encounters. All this data is available because it's contributed, sometimes through mandates, to the HIE. This bill adds 2 more critical data sources: skilled nursing facilities and existing data feeds from electronic health networks. By sharing this data, we'll have enough or even more tools for public health and patient safety, while at the same time reducing the burden for our clinicians. Again, I thank you for supporting this matter. Thank you for your consideration on Senate Bill 748, and I urge the committee to move the bill forward with a favorable report.
Thank you. Are there any questions of the sponsor? Okay, then we'll go next to Craig Baim.
Hey, good afternoon, everybody. I'm sorry, I can't seem to start my video. The host is blocking it, but I'll get started with the testimony. There we go. Thank you so much. Thank you, Senator Vital. Good afternoon, Madam Chair, Vice Chair. Thank you for having me. I'm Craig Baim. I'm the Executive Director for CRISP. We are Maryland's State Designated Health Information Exchange. Comprehensive data is essential for fulfilling the mission of our HIE. And as Senator Vital said, Senate Bill 748 will further enable us to leverage existing connections to share broader care team information, reduce physician burden resulting from the current manual file uploads. It'll support public health initiatives. It will help us prepare for strategic decisions related to Maryland's unique total cost of care model. And it's just really going to drive the breadth and depth of what we can do as an HIE. And really, our HIE functions kind of very much like a utility for healthcare data. There are many contributors, such as hospitals, clinics, pharmacies, payers, even community-based organizations. This bill adds data by using existing administrative transactions shared through electronic health networks and reports from skilled nursing facilities. None of the current hospitals, pharmacies, or other groups are paid to contribute patient information, and the HIE is very purposely limited in what we can do with the information. But by having this unique infrastructure, we essentially have an asset that's used across the healthcare industry for patient safety, public health, and better outcomes. I'd like to briefly illustrate the importance of the HIE by sharing just a few of our contributions to the COVID-19 response. We used the lab results to identify confirmed cases, and then we notified providers and first responders. We collaborated with the Maryland Department of Health, and CRISP is actually the starting point that triggers the contact tracing workflows. We worked with the University System of Maryland in a really brand new use case for us, where we take the student lists, combine them with testing information, and share a broad understanding of infections that are occurring on campuses. Now with the pivot to vaccinations, we're once again repurposing the HIE for these important community services. As you all know, Marylanders are signing up for as many lists as possible, and then they stay on lists even after they've been vaccinated. What CRISP is doing is comparing hundreds of thousands of patients across dozens of administration sites with the statewide vaccine data to indicate the people who may have already been vaccinated. It allows us to take tens of thousands of people off some of these longer lists. And that way, the health departments, the hospitals can focus their resources on the outreach for vulnerable patients who can't get registered. We have fewer missed appointments, fewer no-shows, and we're just not wasting time with people who've already been vaccinated. All of this is only possible because CRISP is giving copies of data. If the HIE had these new feeds last year, our public health response to COVID-19 would have been more comprehensive. And I keep on using this word, but this is really unique. Many other states have patient information that's only sent through these point-to-point proprietary connections, and they can't have this infrastructure that does all the public benefit for health and safety that we can do. We've been working collaboratively on this bill for many months. There are some friendly amendments from our partners at Lifespan, and I know Care First had some additional descriptions they'd like to add, and we agree with their recommendations. And so I'm really excited about the possibilities presented here, and I thank you for your time and urge a favorable report.
Thank you. Are there any questions for this witness? All right, then we'll go to Ben Steffen of the Health Department.
Thank you, Chair Kelly, Vice Chair Feldman, members of the committee. Chair Kelly, it's always a pleasure to come before your committee. As I think I've told you, my mother is Dolores as well. So it's a kind of a coming home experience. But I want to first off thank Senator Beidel for introducing this bill. The Healthcare Commission is strongly behind this legislation. And I want to emphasize 4 major points and why I think this is important. First off, we know that there were significant deficits in information flowing from patients that were residing in nursing homes over the pandemic. This initiative would help us resolve some of those information gaps. At the same time, the information that we're going to be able to receive from administrative networks are going to be important for further billing out a comprehensive record for more Marylanders. 4 things to keep in mind. CRISP has shown technical expertise and enormous initiative. They're almost entrepreneurs over the span of the pandemic. This was the data initiatives over the pandemic were really a coalition of the willing. It included public organizations, organizations from outside the state, including the District of Columbia and the state of Virginia, private sector firms as large as Apple and Google. But what I can say, frankly, is CRISP stood out among all of those in their ability to put new systems together quickly and provide effective information for those that were on the first line. Secondly, information held by nursing homes and electronic networks are going to be valuable in our efforts as we move forward. Following the Willie Sutton approach to data aggregation, we should go where information is residing, and that information will be very helpful as we move through the pandemic into the post-pandemic phase, where there are going to be remaining enormous challenges, not only with the existing conditions, but also with the remnants of the pandemic over the next couple of years. Third, privacy will be protected. There are existing protections through CRISP today, a companion bill, which we hope to introduce either this year or next year, would provide additional privacy protections for patients through which data is shared through the Health Information Exchange. And finally, the key role of the Healthcare Commission cannot be overemphasized. David Sharp, who's with me today but is not speaking, has led efforts to build a a collaborative framework in which we balance the needs of multiple stakeholders in developing information sharing and privacy protections as information flows through the Health Information Exchange. We started this in 2011 when the exchange was but an idea, and we've carried it forward, and we are committed, should this legislation pass, to work with all stakeholders to build a fair, equitable, and balanced approach to moving this effort forward. We encourage the committee to issue a favorable report on Senate Bill 748. Thank you.
Thank you. Are there any questions of this witness? All right. So then we're going to Dr. Bone of MedCai. Doctor, if you'll just unmute yourself. You'll need to unmute. Can you? Yes.
Yes. Am I clear now?
Yes.
Good evening or good afternoon, Chairwoman Kelly. Hello to Senator Benson and other senators. I'd like to rise in support of Senate Bill 748 on behalf of MedCai. I'm George Bone. I'm primary care physician in Prince George's County for the last 35 years. I care for patients with diverse backgrounds, conditions, and preferences for care locations, be it in office, telehealth, urgent care, emergency room, or nursing homes. I urge you to support this bill because it allows me to better know and care for my patients. It's hard to render comprehensive care without complete information, and this bill would provide that information. Medical information is concentrated in two areas primarily. One is hospital-based, and the second is in the billing cycle. Hospital-based information reporting to CRISP is already mandatory. This bill will make information reporting from the clearinghouses and nursing homes to CRIS also mandatory. By making this information available to CRIS, will permit more comprehensive reporting back to the participating primary care physicians, allowing them a 360-degree vision of the care being rendered to their patients. As a primary care physician in an underserved area, in all cases, I can provide the best care by knowing where my patients have been and who their other caregivers are. I use CRIS to follow up with patients when they're discharged from a hospital because this reporting, as stated, is mandatory. But CRIS is limited currently in its ability to report non-hospital acquired care, therefore at times unable to let me know when to follow up because a patient has been to an urgent care facility or a nursing home. Additionally, if I refer a patient to a specialist and the patient does not go, I may have to wait until our next routine follow-up visit to find out. I urge you to support this bill because it would close these gaps in readily available information so I can better care for my patients. Another feature of this bill that is useful is the reduction in manual data entry. While I'm an active user of CRIS, I have to submit a manual list of my patients every month so they know who my patients are. My electronic health record vendor is not allowing me to connect with CRIS directly without a significant connect fee. I would like to use the outbound messages I already pay to send through my electronic health network clearinghouse to tell CRIS who my patients are. I'm doing this with lab results at no cost. Finally, an important area is in population health that I'm working with MedCai and my local hospital to achieve success under the Maryland's unique model. It's hard to have strategic discussions without complete information, and this bill would provide that information. For these critical reasons, I urge favorable support on this bill, and I thank you for your time and opportunity.
Thank you very much. Are there any questions for Dr. Bone? Okay, then we'll go to Robin Elliott, the Maryland Nurses Association.
Good afternoon, Chair Kelly and members of the committee.
Robin Elliott today, as Senator Kelly said, on behalf of the Maryland Nurses Association. We are supportive of this bill because of the patients that nurses serve. Having data for nurses to care coordinate, do better case management will improve patient outcomes. And it also improves the lives of the patient's families. We all may have experienced having a family member in a nursing home for some reason. And when they're discharged, there is an enormous burden on the family to make sure that the individual's health records get from the nursing home to their other care providers. So this will lift that burden, and it will improve care coordination for things like occupational therapy, wraparound services like medically tailored meals, and primary care. So we ask for a favorable report. Thank you.
Thank you. Senator Benson, I saw your hand, but not until she was speaking. Did you have a question? You got to unmute. Yeah. Okay.
I don't have a question, but I do have a statement. I just want you all to know that this wonderful doctor, Dr. George Bone, has been my doctor for over 25 years. He is the person who keeps me looking so good. And I want to say hello to my wonderful doctor. There's nobody finer than this wonderful, 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 wonderful doctor. He is outstanding and I love him.
Thank you, thank you, thank you. You're in good voice. Thank you.
And she must have good health care to speak so soundly about your assistance.
Thanks.
Thank you very much. Okay. We're going then to Dana Kaufman, who is favorable with an amendment.
Thank you very much, Chair Kelly, members of the Senate Finance Committee. For the record, my name is Dana Kaufman, and I'm here on support of Senate Bill 748 on behalf of Lifespan Network. I first want to thank CRISP for all of their efforts that they gave to us during the last year with the pandemic. As you know, it has been a very chaotic year, and oftentimes with revised guidelines and directives, we relied on CRISP, sometimes frantic phone calls, to help us with the reporting requirements that we were under through the health department's directives. So I just wanted to put that out there, that we very much value the relationship that we have with CRISP. We do support Senate Bill 748. What we have seen over the last year, of course, even more so than before, is the importance of sharing data with our healthcare partners and the need to coordinate that care so we can have better outcomes as it relates to, of course, both the patients, but also our goals under the total cost of care model. The amendments that we have put forward through CRISP simply clarify the uses of the information that is to be reported. And with those, we would request a favorable report. Thank you very much.
Thank you. Are there any questions for this witness? Okay. Well, that ends the testimony on Senate Bill 748. And thanks to everybody.
Thank you very much. Yeah.
Back to Senator Battle for her other bill, Senate Bill 705. State airports, commercial activity, rental vehicles, and peer-to-peer car sharing. Senator, you got all the time you need to lay out the parameters of your bill. And we've got Michael Johansson as your lead proponent, who will get the 5 minutes, and your other witnesses will have 2.5 minutes each.
Thank you again, Madam Chair and members of the committee. Thank you for hearing Senate Bill 705. For the record, this is Pam Beidle. You've heard a lot about rental car peer-to-peer sharing in prior years. That we actually began working on this. The committee began working on this in 2017. So Senate Bill 705 requires that companies in the business of renting cars, whether they are a rental car company or a peer-to-peer car sharing platform, operate under the same set of rules at BWI Thurgood Marshall Airport. In 2017, the committee created a statutory framework for peer-to-peer car sharing. That framework, which included insurance and various consumer protections. I actually was helping with the Senate policies back then. I came over from the House and worked with our prior chair. But they're given nearly identical requirements to set forth for traditional rental car companies. And because peer-to-peer operators had ignored several cease and desist requests from the MAA, this committee tried to make it clear in that legislation that peer-to-peer companies conducting operations at BWI had to first enter into a concession contract. Unfortunately, it's apparent that we were not clear enough, because in the years since, peer-to-peer companies are still conducting operations at the airport without a concession agreement. In fact, I raised this very issue on the floor last year when P2P companies were asking this state to continue granting them preferential sales tax treatment. Today, incumbent rental car companies operating at BWI are required to charge customers concession, facility, and transportation fees. Operationally, customers are required to take a shuttle bus from the airport terminal to the consolidated rental car facility in an effort to keep rental activity away from the terminal. Yet for years, peer-to-peer operators have conducted commercial activity at BWI without charging the consumer any airport fees and have simultaneously utilized the terminal or on-site parking garage to conduct their activities. This unfair advantage undercuts existing operators who employ hundreds of folks in my district and also results in a loss of revenue to the state. Senate Bill 705 helps to ensure businesses competing for the same customers are competing on equal footing. Ultimately, we should not be in the business of picking winners and losers within the same industry. For these reasons, I ask for a favorable report on Senate Bill 705. Thank you for your consideration.
Thank you. Are there any questions for the sponsor? Okay, then we're going next to Michael Johansson.
Thank you, Madam Chair. I'm Mike Johansson on behalf of Enterprise Holdings. Thank you, Senator Bayh, for introducing this important bill. I know you're not going to be able to see this, but I was able to text to those of you who have your cell phone a little screenshot from a website. And what it simply says is, Turo, the world's leading car sharing marketplace, empowers independent rental car companies and entrepreneurs around the world to tap into our global network of millions of pre-screened guests. Sign up today as a commercial host in the United States by providing your own commercial rental insurance and keep 92.5% of every rental you win via Turo. List your fleet for free. So when we have a further conversation about this bill and you hear from the opponents that car sharing is not rental, and you hear from the opponents this bill is only about mom and pops versus the big rental car companies, Turo solicits rental car fleets to appear on this app so that people can rent cars. In some cases, the same rental cars that rental car owners have. The bill is very simple. Don't let others confuse you. All we want is a competitive situation at BWI. We want competitive fees and we want a competitive operating model. No one is seeking to exclude these services from the airport or to exclude any individual competitor. The history on this bill goes back much further than 2017. Senator Bayh caught you up to the recent era. But if you go back 20 years ago into the late 90s, the airport decided to move the rental car companies from the parking lot in front of the terminal right behind the hourly garage to a brand new consolidated rental car facility. The rental car companies didn't really want to go to a consolidated rental car facility because that meant people would have to get on a shuttle bus and travel through the traffic to get to this brand new building. The second reason the rental car companies didn't like it, because the rental car companies' customers were going to have to pay all of the costs to build the building and maintain it, pay for the cost of the buses, and pay for the cost of operating the buses. So those fees are now all built into what the airport created 20 years ago when they said, rental car companies, get away from the terminal. We're going to move you to this field 2 miles away that takes basically 15 minutes round trip. When they did that, the rental car companies also said, well, wait a minute. We have these off-airport operators who, you could either be on the airport near the terminal, or you could have your own little shuttle bus and go up in Linthicum in Senator Bidel's district. You can rent a parking lot and then you can shuttle your customers in. And the rental car company said, if we're going to have to be moved to a shuttle location, it would be unfair if the off-airport rental car companies were able to use their own shuttle bus, come in and pick up the customers at the curb, treat them really well, and take them to their own private lot. So the airport worked out a regulation in COMAR that said off-airport operators can't pick up at the terminal anymore either. That off-airport operators would have to go to the consolidated rental car facility, which means any customer landing at BWI who wants to rent a car takes the same shuttle bus to the consolidated rental car facility, and they either rent from one of the on-airport operators who are there, or they take a second shuttle bus owned by the second off-airport company, and they go off-site. So there were these critical terms negotiated as part of this major investment of state funding: how to pay for it, how to ensure it was fair, and how to make sure that off-airport rental car operators were treated in a way that was fair to them, but they didn't get an advantage toward the on-airport companies. There was another significant term in those contracts from 20 years ago. The airport promised, we aren't going to guarantee you, Avis or Budget or Hertz, that you're the only one here at the airport. But what we promise you is, if anyone ever comes on this property and has a like service, didn't say rental car service, it says a like service, we will not give them terms more favorable than the terms you have in your contract. That promise was made 20 years ago, and these companies have bargained for it, and it's still in their contracts today. So what has recently happened in the last couple of years is peer-to-peer car sharing operators who use advertisements on their website that say, rent a car at BWI, 3 days, $40 a day. You can pick up here. They've been picking up at the curb. They're picking up at the daily garage. They don't have a concession agreement at the moment. They're not paying a concession fee. The off-airport operators are not paying a concession fee either. They are clearly conducting commercial activity. When the opponents say to you, we don't need a rental car counter, that's why we don't want to go to the consolidated building, I can assure you now, most rental car customers go straight to the car. They don't have to stop by the rental car counter anymore.
Mike, you've used your 5 minutes. Can you wrap up in about 30 seconds?
I certainly can. Thank you. I appreciate it.
Pick up from there.
Secondly, I mentioned these aren't necessarily just small mom and pop operators, okay? And lastly, really the question that I have for the committee, why does a company which claims to be an upstart and an interruption company, why do they need advantages so that their product can sell? They can do the same thing we're doing, and we are welcome to have them. They can join us at the consolidated facility. We'll make space for them, and they can pay their own fair share. Whatever the airport decides that fair share is, this bill does not determine that. Thank you, Madam Chair.
Okay. Any questions for Mike? All right, we're going to Andy Dollar from Enterprise.
All right. Good afternoon, Madam Chair, members of the committee. I'd also like to thank Senator Bidel for putting in this important bill. And
you might want to project a little more.
Okay, I'll yell a little bit louder. I apologize, you couldn't hear me. My name is Andy Dolliff. I'm the Vice President and General Manager at Enterprise Holdings. I oversee the majority of the operations in the state of Maryland for Enterprise, Alamo, and National Car Rental, including BWI Airport. I think Mike gave an incredible summary of what's been going on for the last 4 or 5 years. I'd like to highlight just our impact in Maryland and who we are as a company, because I think that's incredibly important that we are a Maryland company. We employ just under 2,000 Marylanders. Our payroll is about $91 million, which contributes about $6 million in payroll taxes. We pay just about $1 million in property taxes, $4 million in vehicle registrations, and the slide deck will show you that we pay about $63 million in sales tax and about $167 million in direct activity to the state. We also pay about $7.8 million in concession fees at BWI for the reasons that Mike laid out, and another $2.5 million to bus our customers to that consolidated facility. I know I gave you a lot of numbers and I'm not trying to put you to sleep on a Wednesday afternoon, but I want to just cover the main premise that everybody's talking about, which is what we've been seeking for multiple years now. Number one, we are a good Maryland business. My office is headquartered here in Linthicum, Maryland. Number two, there's a set of fees and taxes to rent cars in the state of Maryland that have been established for multiple years. We're not looking to change those. And number three, there's a set of fees and taxes to rent cars at BWI. There's simply rules to play by in the rental car industry. And all we're looking for is everybody that rents a vehicle in the state of Maryland to play by the same rules. Like Mike mentioned, we're not some large company trying to keep out a disruptor or a new company or a tech company. That's not our intent at all. But if you give a new company an advantage and a significant advantage on what a customer pays at the end of a rental, that will completely tilt the customers in terms of how much they're willing to spend, in terms of who they would rent vehicles with. And what we're looking for is for customers to pay the same taxes and fees at the end of the day. Mike laid out why there's a consolidated facility. It would be a disaster if cars were being rented, thousands of cars at the curb every day. That would be an absolute disaster from a safety standpoint and from a BWI standpoint. So it's important that everybody goes to an offsite airport. That's not just in the state of Maryland. Many airports do that. So again, thank you to the committee. We certainly just want fairness and parity across the rental car industry. Thank you for your time.
Thank you. Are there questions of this witness? All right, then we're going to Michael DeLorenzo, Next Car Rental and Leasing.
Good afternoon, Senators. That's me. I'm Mike DeLorenzo, and I operate Next Car, which is a Maryland firm. It's founded in Maryland by Marylanders, and we're headquartered here in the Laurel Lakes Office Park. I've been serving your constituents and my customers in Maryland for the last 52 years. So recently, you've probably heard a lot of talk about how car rentals not paying excise taxes. That was the big newspaper article last week. So in my piece that I turned in for you all to see, there's 4 boxes that try to explain the taxes that car rental pays. We do pay taxes. They're called car rental taxes. And when you compare to 2020 motor vehicle records, the average new car in Maryland paid $2,225 in excise tax in 2020. And that car is going to be kept for 5 years or 5.5 years until it's sold and generates another excise tax. So excise tax has a 5-year shelf life. Car rentals pay tax every year. We pay 11.5% of our gross revenue. And over the same 5.5-year period, a rental car will generate $7,800 of tax for the government of Maryland. So when you compare $2,200 to $7,800, I would like to proffer that we are paying taxes. They're just not called excise taxes. Lastly, the points in addition to what Mike Johansson's already said is the courts in California, the California Superior Court has ruled that Turo is a car rental company. And just recently this year in Massachusetts Supreme Court, they ruled that Turo is a car rental company. So there's no reason to be treating Turo better than you're treating me. I was forced to come up with $1.5 million to build a building to go in terminal at BWI Airport. I'm just a little operator running the smallest piece of market share at BWI Airport. And there's absolutely no reason why you should be granting special privileges to a big tech California firm that has no investment in the state of Maryland. Thanks for listening.
Thank you. Are there any questions for this witness? Okay, we're going next to Rob Gargiola, Compass Advocacy.
Great. Thank you, Madam Chair and members of the committee. I want to also thank Senator Bidle for being engaged on this issue for many years. You've been certainly a champion on getting parity at the airport. So thank you for your sponsorship of this. Again, Rob Garagiola with Compass on behalf of both NextCar and Enterprise. If any of you go on your computer and just type in Turo and airport, you'll see that them or other peer-to-peer car sharing networks are marketing to consumers the same way as a rental car company. And hopefully we'll all get to travel pretty soon. I generally will, rent a car through my phone, and we're going to be having more and more travelers coming to BWI. And this bill is about BWI, essentially a closed market. So travelers from other states are going to be on their phones or on their computers, and some are going to use a car sharing app or Enterprise. And what I want to direct you to is you should have with your testimony with Enterprise is a kind of a price comparison of what that out-of-state Michigan or Oklahoma customer is going to pay. And so if you look at, a 3-day rental, $40, whether it's Turo or Enterprise or NextCar, the fees are going to be different. What the customer from out-of-state will pay will be different. So Enterprise or NextCar will pay a concession fee for a 3-day rental of $14.43. A car sharing network is going to pay $0. Enterprise, NextCar, other rental car companies are going to pay a customer facility charge for those 3 days, $11.25. Turo or other car sharing will pay $0. That's essentially over $25, nearly $26 that the MAA BWI is not getting for the exact same transaction. It's also a differential of what an out-of-state customer is going to be paying, and think about it from a competitiveness standpoint. But in addition to that, as was mentioned earlier, if you're using Enterprise or NextCar, there's also a shuttle fee of $8.70. Turo would pay $0. This bill is about getting parity at the airport, so there's a level playing field. And then while this issue is not necessarily in this committee, there is a sales tax differential. So again, Enterprise, NextCar would be paying $17.75 compared to Turo, which would be paying $8.15 under current, $9.60 under current law, a difference of $8.50 for that same 3-day, $40 car rental. So the difference is if you use a rental car company that has hundreds or thousands of jobs in Maryland, that pays all the taxes that were highlighted earlier, 3 days, $40 rental, all those fees and taxes, $172.13. But if you're Turo or a car sharing competitor, the customer from Michigan or California is going to pay $129.60. How is that fair from a competitiveness standpoint, where the customer is going to pay over $42 less for one type of rental car business compared to another? It's less revenue for the airport, it's less revenue for the state with sales taxes, and we would argue that this bill is a common sense bill for a closed market at BWI for out-of-state travelers in the fees that they pay to ensure that everyone is playing on a level playing field. And with that, Madam Chair and members of the committee would urge a favorable report.
Okay, are there any questions for Rob? Okay, now we're going to 2 unfavorables. Chris DePietro, CDI Consultant Services, LLC.
Madam Chair, members of the committee, my name is Chris DePietro. I'm here on behalf of Turo. We respectfully are in opposition to this bill. This committee is no stranger to this issue. You all passed what was the first modern peer-to-peer car sharing statute in the country in 2018. As part of the negotiations of that law, one of the provisions that was inserted into the law was that if a peer-to-peer operator was to operate at the airport, they would have to do so under a concession agreement. That law went into effect in July of 2018. Immediately after going into effect, Turo reached out to BWI to begin the discussions on how we were going to proceed with this concession agreement. Granted, it took 2 years to get to an agreement. Agreement was finally reached in July of 2020. Now, one of the reasons it was, I think, it's a disruptor industry. We operate differently than traditional car rental, which is why we have a separate statute in Maryland law, why we are treated a little bit differently. And I think we just need to focus in on what we actually did. We met with BWI. They secret shopped us. Unbeknownst to us, they posed as guests wanting to use vehicles off of the Turo platform and make those transactions happen at BWI. We did not know this, and they want to see what the impact was on airport facilities. Now, granted, you heard in some of the proponents' testimony that, oh, there's going to be thousands of transactions. The airport shouldn't do this. You can't do that all at the curb. The reality is that even before when we passed the bill a couple of years ago, we were doing like one transaction a day at the airport. And I think before the pandemic, it was like 3 to 5 a day at the airport. The car rental industry, I know, is doing many times that. And we don't use the facilities in the same way that the car rental industry does. So we get this agreement in July of 2021. It was a fee model based more like what the Uber, the TNC model, and how that worked at the airport. If you remember correctly, this committee dealt with this issue too. TNCs weren't allowed initially to pick up and drop off at the airport. That came down the road. Then they did, and they came up with a fee agreement that there would be a daily charge, a pickup and drop off charge for every transaction that happened at the airport. They designated a zone for it, much the same way they are doing for us. They designated a zone for where these transactions would happen, and there would be a pickup and drop off fee that we would pay to the airport. So we're not using any of the transportation facilities. We're not using the consolidated rental car facility at all. So we had this agreement, and it was on the Board of Public Works. I mean, in early December, it was actually on the board's agenda. That means it met all the legal sufficiency of Maryland law. AGs looked at this contract. They said it met the terms of Maryland law. If it didn't, I don't think they would have allowed it to go on the Board of Public Works agenda. So what happened is the car rental industry found out about it, and they went to their allies and tried to say, this isn't right, it's not fair. And they tried to stop it. The airport decided to pull back. And that's why we are where we are today. We couldn't move forward with the Board of Public Works under a fairly negotiated contract. And now what's happening is that the car rental industry wants to change the terms and the rules of the road. And we just don't think that's fair, and we respectfully oppose. Madam Chair, Sean Vink is here from Turo. He's not necessarily going to make any comments, but is here to answer any questions.
Okay, I was going to call in. Do you have any questions of either of the people from Turo? Senator Bidle.
Thank you, Madam Chair, and thank you, Mr. DePietro. So there was a reason that that agreement was pulled back from Public Works, and it was because the definition of fleet, Turo did not meet the definition of fleet, and the current rental car fees are based on fleets. And so it was just a legal issue that had to be corrected. So it wasn't about, other of us getting involved or whatever. And so part of what happens in this bill is that we will be, we are correcting the definition.
So Senator, to respond to that, we don't own a fleet. The folks that use our platform. And I want to just kind of comment also, I know Mr. Johansson talked about
well, we can't go back to that. Go ahead and answer this one. Go ahead and finish.
Can I? Okay, thank you, Madam Chair. So commercial hosts that market on the peer-to-peer site are car rental companies. They have commercial insurance. They operate fleets. If they do that on our site under an agreement, they are doing so as car rental companies, and they are obligated under all the same rights and responsibilities that car rental companies have. I want to be clear, there are no commercial hosts operating in Maryland on the Turo platform. They just don't exist. Now there's going to be others that say, oh, well, I can show you this person or that person. What about them? we've investigated all the kind of leads that other members have given us, and they are Marylanders who own their own vehicles who have paid their taxes.
Okay, we've got a question for you from Senator Reedy. And then we want to hear from Senator Hershey regarding his question. Senator Reedy?
It's on mute.
Sorry.
Did you have a question?
Yeah, sorry. Chris, I have some kind of concerned about the fees you're talking. So what is it could you reiterate, what were you going to pay in the contract? What was the firm going to be paying? What kind of taxes and fees?
Well, let's
set up
be
you were
clear
gonna
about the
have?
issues. The taxes and fees are all part of a separate piece of legislation that's being considered in the Budget and Tax Committee. This bill doesn't deal with any of that.
But we still want to know.
I'm just trying to understand.
Absolutely, and it hasn't, quite frankly, it hasn't been resolved yet. But we negotiated with the airport, with the MAA, a concession agreement that is similar to what TNCs do. It would be a $2.50 drop-off fee and a $2.50 pickup fee. So the total transaction for one person going in and out would be $5. So that's what, and we were designated a certain amount of curb space at the airport where the transactions would take place. And let me tell you, if we have estimates about how much usage we would have of that curb space, if it grew beyond the ability for that curb space to handle it, BWI is within its right to renegotiate that contract with us and say, okay, you guys need to go over here now, and your patrons need to use a shuttle bus to get over there. Then that's a different ballgame. We're not there yet. So at this point in time, it was just $2.50 each way.
Okay, I have one follow-up, Madam Chair, is if what stops your people on your site from picking somebody up at the airport and driving them off site and then loaning them the car at, the Royal Farms down right off of 97 or whatever? I mean, what obviously that wouldn't be very professional. I'm just curious.
No, Senator, just to be clear about how the transactions work. So, Turo is the platform. We're the peer-to-peer platform. It's the marketplace, for a lack of a better word.
Yeah.
We connect the hosts, the owners of the vehicles, with the people who are the guests who want to use the vehicles.
Right.
Turo, as the platform, does not dictate where the transfer of the vehicle will take place, or quite frankly, that the terms that the owner of the vehicle wants to have a charge for the use of that vehicle. So that is up to the owner and the guest. And in this case, if they decide they want to do that on airport facility, they would do so under this contract, and they would do so at the designated curb space as dictated by the contract.
Okay, so
we don't have a contract right now, so I want to be very clear.
I understand.
This is what's happening today.
Okay.
Okay, I'm working.
Right, you got your.
Okay, thank you,
Senator Hershey.
Thank you, Madam Chair. Chris, in your response to Senator Reedy there, it sounds like Turo X more like a livery industry than the rental car industry. I mean, you equated yourself more to in the agreement that you had with taxis and Ubers. Is that accurate?
Well, I think so. I think the transaction. So this transaction does not work the same way a transaction would work in the traditional car rental industry. So that's why it's a little bit different. The transaction is taking place between a person who owns the vehicle. Again, Turo does not own vehicles. We do not operate any fleets. We don't own one car. The host, the person who owns the vehicle, would make the arrangements with the person who wants to use that vehicle as to when that sharing period will begin. And this is all laid out by the law that you all passed in 2018. So that's how it works. So when the BWI did some secret shopping on our product, I think to their satisfaction, there's this is pretty much what an Uber transaction, how it works. As far as use of airport facilities.
Yeah.
So that's
Chris,
why I think they went that direction.
right. So you're saying that because of the manner in which you hold or make the transaction, you believe you should be compared more towards a Uber or a taxi. But let me ask, in terms of customers,
right?
What type of customer are you going after? You're not going after the same customer as Uber and a taxi, are you? You're going after more the customer.
It's a different service. I mean, when that transfer takes place, if I was the vehicle owner, I would turn the keys over to you and you were going to use my vehicle for the next 3 days.
As a rental, right?
So we don't, I arrange, if it's my car, I make arrangements to get home some other way, or somebody met me there or whatever. I mean, it's a completely different transaction than Uber or a traditional rental car transaction.
I understand, but you're confusing me because you said that the agreement with the airport was to put you more in line like an Uber or a taxi because of your transaction, the way that you transact.
Because of the type of use that we would have of airport facilities.
Well, that's not what, yeah, okay. You said more.
We don't have any use for the consolidated rental. We don't own a fleet. We don't have a counter. We don't have employees. I know the senator likes to point that out. We don't have employees at Turo who are in Maryland. These are your constituents that are using the platform to earn a little extra money.
Right, but my constituents also work for companies that rent cars as well too, that pay taxes as well too.
Absolutely.
So I'm more concerned with not how the transaction occurs, because I'm sure that these rental cars companies also have apps that would allow them to do everything online as well, or through the app. And as we heard testimony already is yes, certainly somebody's forced to ride a bus and forced to go all the way to a rental car center just so they can get off the bus and walk to a car. So that transaction is one thing, but the main thing on how I would think you should be categorized is the customer that you go after, and who you are seeking, who your companies are seeking as their customers. And to me, Turo sounds much more like a car rental company than it does a transport company.
I wouldn't disagree that the customer base is the same, but the delivery method is different. And I would say in response to that, Senator, is that BWI knew what they were doing when we entered into, they weren't forced to enter into this contract. They evaluated it independently. They secret shopped us. They made a determination that this is something that we want to have as a option for the travelers that go in and out of BWI. They saw the impact on airport facilities, and they decided it was appropriate. So if BWI didn't think it was appropriate, they wouldn't have entered into that contract. They did it of free will.
Let me just one more question, Madam Chair, just because you brought up the contract, because Mr. Johansson brought up that within that contract, there was a promise, and he mentioned terms that would be no more favorable for anybody else that comes in. Do you think if you were able to have done the contract that was before the BPW, that the terms for Turo would have been much more favorable than that of the rental car companies?
All I can say is, because I wasn't involved directly with the negotiation from a legal perspective, I'm not a lawyer, but I can guarantee you that attorneys at BWI reviewed this contract to make sure it met legal sufficiency to COMAR and other regulations. Otherwise, it would have never made it to the Board of Public Works agenda.
Okay. Well, obviously it was pulled, so there was some
concern
about that. So,
yes.
Okay. Thank you, Chris. Thank you, Madam Chair.
Thank you.
I think that ends the testimony on this bill, which is very exciting. Senator Battle, did you have a question?
I just had two quick things, if I can, Madam Chair. Back to why that contract at $2.50 was pulled. The airport was required by our law last year to make a concession agreement, and that was their only option legally at the time. And that's why we have this bill to correct that, so they have other options. And it's so busy at BWI that even during the holidays, our shuttle buses have to go to a different floor. They have to go to the arriving floor to pick up people, to the departing floor to pick up people instead of the arriving floor. So we don't need additional traffic going around the airport loop. And so that's also part of the issue with Turo. Just those closing comments. Thank you, Madam Chair.
Thank you. All right, we're going now to Senator Kramer, Senate Bill 682, Senator, you got all the time you need to lay out your bill, and your lead proponent is Harani Jago Shion. Okay, that's the person who will have the 5 minutes.
Thank you for that, Madam Chair. And I've noticed there seems to be a pattern that Ben Kramer's been doing a lot of the cleanup in the committee lately, but that's a good thing because I know you are all still energized and tuned in. So I'm here to introduce Senate Bill 682, which committee will sound a little familiar and probably more familiar as we go along, because I introduced this bill last year. And what it does is it provides an individual who enrolls in Medicare to have 6 months in which to take advantage of open enrollment in a Medicare supplement policy, typically referred to as a Medigap policy. So when they first enroll in Medicare, they have a 6-month window in which they can get into a Medigap policy. But during this time, the coverage can't be subjected to underwriting that might look at the individual's existing health condition for purposes of pricing. This is required by federal regulations, this 6-month window. States are permitted to go well beyond what the federal regulations indicate with regard to this issue of being able to adjust policies. In Maryland, though, at the moment, once the insured is in a program, they no longer have the right to move to a different company without being subjected to the underwriting process. You can do that in the open enrollment periods in the Affordable Care Act, but in Maryland, for this Medigap policy, the supplement, you can't do that. So if a senior finds that they may have coverage that may not make sense for them because of unused coverage or cost, they will be required to submit to underwriting if they seek to move to a policy elsewhere. This bill provides an opportunity for a senior to change their policy coverage to a different company within 30 days of their birthday each year without being subjected to underwriting if they are switching to a policy of equal or lesser value. The point here is to give our senior residents the greatest opportunity to address their medical needs and balance their expenses in a way that makes sense for them after they've had an opportunity to experience this policy that they signed up for. And once again, the policies are intended to supplement coverage where the underlying Medicare coverage leaves a gap. And very often it can be a significant gap and can bankrupt a senior who does not have coverage or does not have proper coverage. Oregon and California, the 4th largest economy in the world, that's California, offer this option to their seniors to save them money. New York and Connecticut provide their seniors the option to save money by changing companies at any time during the year without going through underwriting. So New York says you can change anytime you want. California does what this bill before you would do. You have 30 days once a year following your birthday to make this change. Now, the opposition is going to argue against the bill, claiming that they believe that passage of this legislation will cause rates to increase. But at least to this very date, they have never offered any proof or justification for this representation. And the reason I am pointing that out to you, committee, is that at the bill hearing last year, I was questioning one of the individuals who's going to be opposing the bill today. And I asked her, does your company or any company opposing this bill have any empirical data that would indicate there's an increase in costs to our seniors? Because they know the reflex of bringing out the increased cost boogeyman is that everybody's going to go, well, we don't want to do that. So they put it out there, dangling it on the fishing line without any proof of it being correct. So at last year's hearing, I asked for empirical data to prove that they were right, that it would increase premiums. We were promised, Madam Chair, we were promised, committee, that within 1 week of that bill hearing, we would have empirical data proving that costs would go up. Madam Chair, you indicated at the time you would give them the week before voting the bill. Well, that week went by, and an additional 53 weeks have gone by, and we never received the data that we were promised would prove that the opponents claim that costs would go up. I checked my files. I spoke with committee counsel yesterday. They went back to the committee file. Nothing was ever received proving these additional costs. But here's what did happen in the 12 months since that hearing. The House and Government Operations Committee asked that the Maryland Insurance Administration look at this issue and come back to the legislature and tell us, are costs going to go up? What's going to happen? Well, the Office of the Chief Actuary of the Maryland Insurance Administration took up this very issue in the past 12 months. And in December of this past year, produced a better than 40-page report that was sent to those of us in the Maryland General Assembly addressing this claim. Would costs go up? And would competition be thrown into chaos? Let me read to you, and I have asked that this be made available. I believe it's available to every member of this committee, the document that I'm referring to. And if you can't get it, it was sent, I believe, to committee counsel yesterday or the day before, asking them to provide it to each of the members of the committee. But I will be happy to hand deliver it to you. But I don't want anyone to take my word for it. So I sent you the entirety of this 40+ page report. But here's what it says in sum. As discussed in more detail below, the data available to the Office of the Chief Actuary does not demonstrate that the adoption of the birthday rule in Maryland would reduce competition, choice, or introduce anti-selection, or increase rates in the Maryland Medigap market. That's from the Office of the Chief Actuary, and they make reference in this document, committee, that they used empirical data. Exactly what I asked from the industry last year that we were promised we would have in 1 week and never received. Well, the Maryland Insurance Administration took it up. They have made their conclusions, and they also, and I would ask you again, please read the document, make it very clear that while they acknowledge this is a policy decision for the legislature to act on, it appears that it would provide greater opportunities for our seniors, particularly those with illnesses, to be able to find appropriate policies that make sense for them, because otherwise they may be locked out of a market that does not give them the opportunity to find coverage without going through underwriting. So with that, Madam Chair and committee, I have put the facts before you, and I hope when the opposition opines about their beliefs, that you will recognize what is fact and what is fiction. Thank you, Madam Chair.
Thank you. Are there any questions for the sponsor? All right, if not, then we're going to Harat Jagochian, dialysis patient citizens.
Sure. Thank you, Madam Chair, and committee members, and thank you, Senator Kramer, for introducing this legislation. My name is Haran Shamgoshan. I serve as the CEO for a patient advocacy group called Dialysis Patient Citizens. In some of my testimony, I talk about how vulnerable a patient population this is. And at the same time, I think folks forget that about half of our members are under the age of 65. And on the one hand, I'm absolutely grateful that Maryland requires that for those under 65 patients, there's one Medigap option that's required to be available. It's not a community rated option. It's the Plan A option. It's, requires that it can't be more than the average of the premiums of the plans offered. And so I think to put it in context as to what Senator Kramer is asking, so whether they're a really vulnerable dialysis patient, whether they're a senior, he's not saying, let's make sure that whether you're disabled, whether you're, ESRD patient, that these patients, under 65 who potentially could be the more expensive ones, we're not going to add the requirement that they be community rated. They're plans B, plans C, plans D, plans F, plans G, plans K, plans L, plans M, plans N, that all of these options, potentially be opened up. What he's basically saying is, let's have one time of the year that a patient can go ahead and decide if it makes the most sense for them to change. And I really appreciate, Senator Kelly, you sharing how your primary care doctor moved, because for our membership, many dialysis patients are trying to get a transplant. Transplant is the optimal form of therapy. And unfortunately, in 2019, about 5,000 Americans died while waiting for a kidney transplant. So this is literally a matter of life and death. So if there's a transplant center that decides we're not going to go ahead and accept this Medicare supplementary insurance anymore, and so that patient is going to have to try to find a different transplant center and start the entire workup process to get back on the transplant list at a different center. And because that's a different center they may have to commute to. And that's not a instant, you just like with, COVID, you put your name on an email list. I mean, we're talking at least 6 months worth of health workups, or mental health workups, of financial oversight of their, finances to make sure that they can pay that coinsurance. And it's absolutely critical. I think people forget that Medicare, it only covers 80% of the cost of care for patients. And to have that 20%, covered is absolutely essential for our members to be able to get access to a transplant. Otherwise, a lot of transplant centers will require them to show a bank account of $20,000, $30,000, $50,000 to show that they can afford to pay for not just the medications, but the cost of that transplant surgery. And so I want to take this opportunity. One, it is an incredibly important point just to illustrate for our members to have that option to change, especially if they're network. And so I'd like to thank Senator Kramer for taking this stance. And also, as the insurers push back and it's going to drive up costs, remember that the state could do so much more. They could do community rating. And this is just a small but very important step to help these patients. And so thank you, Senator.
Thank you. Are there any questions of this speaker? Okay, we're going next to Charles Arian.
Thank you, Chair Kelly, Vice Chair Feldman, and members of the committee. My name is Charles Arian, and I've been a resident of Montgomery Village and rabbi of Kehillat Shalom Synagogue since July 2012. I want to thank the General Assembly for its continuing hard work in protecting health coverage for the citizens of Maryland. My wife, Kelly, qualified for Social Security disability in 2013 due to severe hearing loss, arthritis, and fibromyalgia. On January 1st, 2015, she became eligible for Medicare. She is 60 years old. I'm testifying instead of her because her hearing loss was adult onset. She does not sign well, and she has great difficulty using Zoom. Because of the size of my synagogue, it does not and never has offered health insurance for employees and their families. I buy my own insurance through the marketplace, and I'm grateful that Maryland's reinsurance plan has meant that my premiums have decreased yearly for the last 3 years. When Kelly became eligible for Medicare, we naturally purchased Medigap coverage. There was not a lot of shopping around to do since all carriers who offer Medigap coverage to those under 65 all offer only one plan with the same benefits. In 2015, her premium with United Healthcare for their AARP endorsed plan was $187 per month. Last year, 5 years later, it had gone up to $294 per month. So we shopped around for another plan. She applied for 2 other Medigap plans and was denied. This year, it is $351.50 per month. So that more than wipes out the savings to the decrease of my insurance. I reviewed her Medicare account from last year, and the amount that her Medigap policy actually paid out to providers was approximately $300. We considered, under the circumstances, simply giving up Medigap coverage altogether. But the fact that there's no out-of-pocket limit to Medicare makes this too risky. So we are now paying $351.50 a month for the peace of mind that suffering an unexpected illness or injury won't bankrupt us. We fall into the category of people who are too rich to qualify for health insurance subsidies, but poor enough that the cost of insurance, co-pays, and deductibles are a real burden for us. It stands to reason that a person who qualifies for Medicare before age 65 due to disability is going to have less than perfect health. A number of other states, as has been mentioned, have Medigap open enrollment periods, and Maryland should as well. Thank you very much.
Thank you. Are there questions of this witness? Thanks so very much for sharing. Okay, we're going next to, where am I? To Matthew Celentano, American Health Insurance Plans.
Good afternoon, Madam Chair and members of the Finance Committee. My name is Matt Celentano, here today on behalf of AHIP, America's Health Insurance Plans, in opposition to Senate Bill 682. And allowing an annual open enrollment period would incentivize consumers to switch in and out of coverages based on their own financial and health requirements. This churn could have a negative impact on premiums for seniors. A fundamental principle of insurance involves the pooling of risks. To ensure stable premiums, a pool of individuals must include healthy people as well as those who are less healthy. If a pool only attracts those with higher risk of healthcare needs, adverse selection, average costs increase and consumers face higher premiums. By providing an annual open enrollment period to allow consumers to switch plans, this could result in lower risk and/or financially sensitive individuals switching to an insurer that can offer a lower premium option. Insurers who happen to attract a disproportionate number of unhealthy risks, resulting in higher overall premiums, would essentially be penalized as healthier individuals look to other insurers for lower premium policies. This has a negative impact on competition in the market and could potentially result in fewer choices for consumers. Churn among plans and insurers will inevitably make pricing more difficult because the risk combination of all the given plans or insurers could vary year to year. And for these concerns, AHIP respectfully requests an unfavorable report on 682. Thank you very much.
You know, I feel really torn. I just listened to the situation of a family kind of caught in a catch-22, and I hear the arguments you make as to what the negative impacts would be on providing insurance for a larger pool of people if we permitted what would make sense in his case. Is there anything else you can think of that America's health insurance plans can think of to make things more reasonable for a person in the rabbi's condition?
I think we would always be willing to sit down and have some discussions about potential options, but I know the witness behind me is going to give you some real world examples from an individual company that might be able to assist with that, Senator Kelly.
Okay, then we're going then to Kimberly. Were there other questions for this witness? Senator Kramer. Senator Kramer.
Thank you, Madam Chair. As I noted in my opening comments, we would have dangled in front of us once again this claim that this quote unquote churn would have a negative impact on premiums for seniors. I told you it was coming, but I also asked, is there any data, any empirical evidence to support that claim? So, Matt, I am asking you, now that you have dangled that in front of us, where is the empirical data that supports your claim that that would be an outcome?
Well, Senator Kramer, I can only sort of refer to the MIA letter, which you referred to earlier in your testimony, which showed that there could be plus or minus 2% across Medigap markets. I think that there might be actually more because the actuaries refer to the fact that they only looked at a small sample of the data. I don't think we have enough data. They also refer to a higher denial rate of 5% on new underwritten business. I think that's the potential that could have. So this could be a new gap for seniors.
Matt, I asked you, where is the data, the empirical data that you said shows there will be an increase? Now, in the Maryland Insurance Administration, in reference to what you just said, they say the opponents indicate or claim there will be double-digit increases. Our study shows that it is likely to be plus or minus 2%. That's it. Plus or minus 2%. And that was in reference to your industry claiming that there's going to be double-digit increases. So they're saying, nah, that's not what we found.
Well, let me butt in. We're not going to have what's really a debate now.
Okay, well, we're going to continue this conversation after the next witness as well. Thank you, Matt.
Okay. Now, Kimberly Robinson is next from Cigna.
Thank you, Madam Chair. This is Kimberly Robinson on behalf of Cigna, respectfully in opposition to Senate Bill 682. I'm going to have to deviate from my planned testimony because unfortunately I have to respond, Senator Kramer, to your statement about whether or not I provided you data last year. And in fact, I intend today to read from the letter I provided you dated March 3rd, 2020, which I handed to you personally while standing in the Senate Finance Committee after bill hearings that day, where I sat and waited so I could have a conversation with you. At that time, the House had already disposed of the corresponding piece of legislation, and I stood and talked with you for nearly 15 minutes about the data that I put in your hand. I'm sorry that you did not include it in your bill file because you probably didn't have it with you physically in the hearing room that day, but I have to, on the record, take offense to the accusation that I did not provide you this data. And as soon as I can take the Zoom screen down, I will send it to you now by email. I don't have to rewrite it. It's sitting in my inbox, or rather in my computer in front of me. I am compelled to make this statement as a professional who did her job last year, and I just can't let it stand on this public record, the accusation I didn't hand you that information.
Okay.
But to continue with the testimony specifically on the bill and why it causes us concern, it is in fact because of our real world experience as a Medicare supplement writer in states that have a birthday rule. Let's see, I'm going to jump ahead in the interest of time. Speaking specifically to the MIA's letter, the MIA does say in their letter that they believe that the average increase in the Medigap pool would be approximately 2%. That is across the pool. That is not our concern. Our concern is with specific products and specific members of the Medigap pool who are going to be the ones who will ultimately feel the change when this happens. And that is in fact based on our experience as a writer, most recently in the state of Oregon, where a birthday rule was adopted. Our experience in Oregon, as we've had to there create a guaranteed issue pool for people who are moving back and forth and in and out of products each year at their birthday, has in fact produced price increases. Now, at the end of the day, as the MIA says, and to that point, the MIA actually even acknowledges in their own letter, and this is a direct quote, that the birthday rule, quote, is likely to drive up the lowest standard rates. Those are the people that we're concerned about. People who are in products right now who are coming in at those lowest rates are the ones who are likely to feel an increase. And that is the reason why adding a birthday rule to what would only be the third state to have a birthday rule in this model in this country is a concern to our company. Again, to say that the MIA's conclusion is for every person in the pool, it's not true. And if you look at the details of their statement in their conclusion, it is a Medigap pool-wide conclusion. So you're taking what might be, in that case, a 10% increase for one person and a 0.5% increase for another, and they've averaged it out across the pool to say the pool might experience a 2% increase. And that's very different than what Joe or Bob or Sally individually could experience under the rule. At the end of the day, it is certainly the prerogative of the General Assembly to make the difficult choice about adding additional choices for moving to a different or lower plan for a consumer against what the potential price increase might be to specific consumers who will be impacted as their insurer may have healthier lives leave that pool and go somewhere else, or have sicker lives who are moving into their pool, creating volatility. The MIA's report focuses very heavily on the experience of AARP, understandably because they are the largest writer in our state. But I would also like to point out that the second largest writer in our state has submitted written opposition testimony, and that would be from CareFirst Blue Cross Blue Shield. With that, I know I'm probably over my 2.5 minutes, Madam Chair, and I appreciate you giving me the personal privilege to have to speak on what was and wasn't done last year. And with that, I will pause and take any questions.
Okay, let me just ask the two of you who did the oral unfavorables, if there is anything that the sponsor might not have thought of as a qualification or the change in his legislation that would bring some relief to persons such as the rabbi, who you heard his story with his wife being disabled and what is happening and the increases that are pretty significant he's had in 2 or 3 successive years. At the same time, it wouldn't undo your contractual relationship and your ability to make a profit as a company regarding, in general, how you are operating.
And Madam Chair, thank you for the question. We are very committed to our Medicare market. It is a very important market to the company. I don't have a specific answer on an option for you today, but I will ask my actuaries, because that's just not my specific area of expertise, to be able to give what would be a well-vetted answer to that question. I'm not sure what could change, but I will absolutely pass that question back.
Matthew, you got any ideas? Any ideas from you, Matt?
I would be happy to talk with my friends at Cigna and at CareFirst, who have been opposed to this bill. I think this year CareFirst submitted a letter, and we can see if we can come up with some options.
Okay, and we got a crossover date coming up soon, so the sooner you can get back to us, I'd appreciate, and I'm sure Senator Kramer would. Okay. that ends the testimony on this.
Madam Chair.
Oh, Senator Kramer.
Thank you, Madam Chair. Kim, I have no recollection whatsoever, and I know there was no documentation in my file or the committee file. But if you say that we had this conversation, I will accept it at its face value. I will also extend an apology and say, then I am sorry if you did present some documentation. I will also say that I am looking at your written testimony.
You want to go tell
no reference to anything in your written testimony that provides any empirical documentation that your assertion is correct. And I would think that if I had this document, you would have incorporated it into your written testimony, but there's nothing here. And in fact, the only thing I see, Kim, is that you make reference in supporting your position today to a Kaiser Family Foundation report from the year 2017.
Well, let me butt in and say this.
Madam
You
Chair,
guys want to talk offline about
no,
that?
Madam
That's
Chair,
not really.
Madam Chair, it is very important that the whole committee hear this. And Madam Chair, I am hoping that this bill will be on a voting list and not end up right here, right now as one of those, well, there's a little disagreement, so therefore it doesn't show up on a voting list.
Well, all of this is kind of out of order. We can have these conversations later.
Which is fine, but that's why it's important for the committee to hear that there has been nothing presented to them that documents the assertions by the opponents that spoke today. To the contrary, I presented a document from the Maryland Insurance Administration that I've given to all of you. If you don't have it, I will. That does validate my position. So thank you.
Okay, but this isn't really about are people nice people or not? Did we make mistakes or not? Recollections that are accurate.
I understand.
Yeah,
So
we
I got, Madam Chair, I'm out.
Madam Chair, I'm happy to provide to the entire committee last year's letter to Delegate Kramer, along with the attachment that does have data as part of it. Yes, Delegate Kramer, it is not in the written testimony that I provided to you today. I did not duplicate that data from last year in the document. I wasn't sure if it needed to be updated, and I didn't have time to have the actuaries look at it to confirm that those numbers hadn't shifted over the last year. But I'm going to be hitting send on my email to you directly, Delegate Kramer, today, and I'll provide it to Patrick.
We appreciate you doing that and let it. All right,
my pleasure.
I've got to. This really ends the testimony on the bill and on it. We had said when we left session today that we would vote a half hour or so after. The staff is ready. So what I'd like to propose is that in 10 minutes, so that if you need a bathroom break or something, we could go ahead and start our voting session. Is that okay with everybody? You have to raise your hand if that works. Okay, then that's what we'll do. Take a 10-minute break and we will start. Thanks so much.